Okay. Okay. Good morning. How is everybody? Happy Monday. It has been a Monday. Yeah. So over the weekend, you guys had 2 chapters of homework, chapters 2 and 3. They were a little bit longer, a little more boring. Anybody have any questions? Any concerns? Anything you don't understand? There is something that I do want to talk to you about from chapter 2. It did say that healthcare providers have to have a minimum of 75 hours of training. If you added up the hours that were here, it's not 75. So this is something that we do need to talk about a little bit. Florida is the only state that doesn't abide by that federal guideline. I don't know why we can get away with it, honestly, but we don't abide by that federal guideline. So in Florida, you do not have to have 75 hours in order to sit for the exam. This doesn't affect your certification in Florida because Florida allows anybody to challenge with no education, experience, or qualifications. Anybody that takes the test, if you pass it, you're a CNA. Great. But if you choose to move out of state, that can work against you. So there are a lot of states that offer something called reciprocity. And we're going to talk about that a little bit more on the very last day of class. But reciprocity just means that we're going to give you a certification in our state based on the fact that you have one somewhere else. You met their qualifications, good enough for us. We'll give you one here too. There is no national CNA certification. Please be aware of that. This is a huge scam going on out there. People are promising to get you a national certification. Just hand us $200 and we'll get it. Yeah, you're throwing there is no national. So be really careful with scams that are out there. People will try to take advantage of you. Anywhere that you want to work as a CNA, you have to be certified in that state. So let's say that you want to go visit some family in New York. You're going to spend an extended amount of time up there. You'd like to make some money while you're there. You can just contact New York and say, hey, I'm a Florida CNA. I'd like to have my certification in New York. They'll say, cool, do our background check, give us a little money, fee, and we'll give you one here. And then you're free to work in that state. And a lot of states do reciprocity, so they don't really care about that 75-hour thing. But there are a few states that are like, hold up, not so fast. We want you to prove that you had an education, something that meets that criteria. And this class is not going to do that. Keep that in mind. This is a test prep. It's not 75 hours. It's not going to meet educational requirements for other states. Okay? So you'd want to know that before you move. Now, New York is one of those states. They're like, we don't care. Yeah, we don't care. Now, that is subject to change, obviously. But there are a few states, I don't remember which ones off the top of my head, but they don't accept anything. You have to start from scratch. They don't accept any other state certification. So I think Tennessee used to be one of them. I've heard that they changed, but I'm not 100% sure on that. I haven't looked at the standards in a while. And California. So if you want to move to those 2 places, just kind of budget that you're going to have to go through the class. All right, good? Questions on that? All right. Let me go ahead and get your scores. Daisy? Chile? Thank you. On both or on chapter 2? What about 3? 2. All right. Emily? That's fine. Madison? Thank you. Michael?
95 on chapter 2, 90 on chapter 3.
Thank you. Sydney? Okay, Sydney, do you have chapter 1 for me yet? It'd be page 181.
I don't think I finished.
Okay, that's fine. Natalie? Adrian? Dakota? Do you have chapter 1 for me? Okay, that's fine. Cheyenne?
I got all of them on chapter 2.
Thank you. Dakota, you said 2 wrong? Okay, thank you. Sierra? Yased? Yaleen?
I got 2 wrong on chapter 2 and 1 on 3.
Thank you. And Uni?
95 on both.
Very good. All right. Do you have any questions on the ones that you missed? Anything that you don't know why the right answer is the right answer? Everybody good? Okay. Tomorrow's a game show. I did check the calendar. I am right this week. Tomorrow is the game show. So tomorrow's going to be a little bit of a special one. It's going to be 20 questions, not 15. And it's going to be skills based. So basically for every skill, I pulled out 1 question and related to that skill. So it's more of a, they're going to test you on the skills when you're in the test, right? They're going to give you the care plan. You've got to do the 3 skills, but that doesn't mean that there won't be skills based questions on the state exam. So this is a way of showing you the types of questions they might ask you that are going to be based on skills performance. So this one tomorrow will be a little bit longer than normal, just because we've got more questions than normal. So feel free to join us. It'll be at 11 a.m. It's direct on my YouTube channel. It's not streamed to any of my websites. It's just direct on my YouTube channel. So just go to youtube.com/4YourCNA. And you can't participate if you're not subscribed. So you've got to hit that little subscribe button to be able to participate in the game show for prize. You can still watch it without being subscribed. That's open to anybody. But if you want to participate for prizes, you have to. It does. It's live at 11, and you'll be able to go back and review it at any time. So it does get recorded and it is available. But you have to find it under my live tab. It's not like in my regular YouTube videos. You got to go over to the live tab to view the replay. Tomorrow at 11. Yep. And you'll be competing for real prizes. Okay. How do we know what to do with each patient? The care plan. All right. We follow the care plan, the whole care plan, and nothing but the care plan. That last part is super important. While we're following that care plan, what should we be making? Observations. And who do we report those to? The nurse. So that's our scope of practice. That tells us what we're going to be doing as CNAs. Remember that every skill starts with the care plan. We have to know what we're doing. Once we know what we're doing, then we can start the actual skill. Now, the actual skill is going to start with the opening. What's the first step of the opening? A knock. So we're going to knock or announce ourselves in some way to let the patient know that we're coming. Once we do that, we're going to greet the resident. Good morning, good afternoon, hello, something nice. Remember, we want to be nice. Once we do that, we want to address them in a very specific way. How do we have to address them? By name. And for the test, just use Mr. or Mrs. Jones. It's very simplistic. Once we have addressed them by name, should we touch them for the ID band? Why? Unclean hands. Very good. So once we've addressed them by name, what do they need to know about us? Name and title. Yeah. So, hi, I'm Patty, your CNA. So, let me tell you a quick story about this. There was a gentleman up in New York. His name is Steven, and he was watching our lives and took a CNA class, but did not feel prepared at all for the test. So he started watching our videos, started watching our lives, and he emailed me 3 times with questions about the test. So I responded to him. Now, I can't always respond to people because my inbox gets overloaded, but I did answer his questions. Well, he just got in touch with me this weekend and said that he took his test. He passed the first time. He got 100 on both written and skills, and credited us with, helping him with that, which was awesome. Congratulations, Stephen. But he said during the test, he was so nervous that he actually did this. Hi, Mr. Jones. My name is Patty. I'm your CNA today. And he's like, oh, wait. And then he had to go back and start again and say his name. And he said the evaluators were puzzled. So he had to explain who Patty was. And they're like, oh, got it. So, but he passed with 100%. From going from I'm not confident to 100%, doing nothing more than watching, how much further ahead are you guys going to be? Okay. So I want to give you a little bit of confidence with that. We get notifications every single day on our YouTube channel, in our emails, through our website, about people that didn't do anything more than watch our videos and pass the test. These methods work. Okay, and it's a lot of repetition to help you remember this. So we're going to introduce ourselves by name and title. Once we've done that, what do the patients need to know about why we're there? What's that? The skill. That's right. So we're going to explain the skill. You can put it in your own words. You can also read it right off the care plan. Does not matter, but make sure that they understand what you're doing. Keep it professional, though. Don't, even if you're putting it in your own words, don't make it unprofessional. We don't want to, we want to make sure that we're doing the right thing here. So once we've described the skill, we need to obtain consent, permission. That's right. Do patients have the right to say no? What should we do if the patient says no?
Ask them why.
Yeah, ask them why and report it to the nurse. Absolutely. Absolutely. But for the test, everybody's going to say yes, they're pleasant and cooperative. We like that. If it was only like that all the time. Once we get consent, we'll go ahead and close that privacy curtain. Now, we're going to close the curtain for every skill except for one, which we'll get to next week. There's one skill we don't close the curtain for, but every other skill we do. We'll close that curtain. Is that curtain clean? So what do we want to do? Wash our hands. Very good. So once we've washed our hands, then we can go get our clean supplies. Don't get the supplies first. Good. Good. Okay. Somebody else left a message on the YouTube channel and asked, why do you go through all this to get, to bring don't you bring your supplies into the room with you? And that's how they were taught by their instructor. You get your supplies and bring them into the room with you. Well, there's a couple of problems with that. Number one, you don't have clean hands. You're touching supplies that are going to be used on a patient and you've not washed your hands yet. Number two, it kind of takes away the patient's ability to say no. It's very presumptuous when you go in with the supplies, because remember, you can't leave supplies in the room if they say no. So we have to discard all of those supplies. So that's kind of a waste of resources. But number three, the other reason that you can't do that is you have no place to put those supplies. So you're going to end up holding them up next to your uniform. And all of those are graded deficiencies. So This seems very simple. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. Seems very simple. But understand that every one of those things hits a testing checkpoint. They have to be done in this order to get credit. Good. Remember, if you put your opening and your closing together, that's half of every checklist that you're going to be graded on. I mean, we haven't even got to the skill yet, and we got half of our checkpoints just through the opening and the closing. That's how important it is. But a word of caution. I've been doing this a very long time, like 17 years or something. It's been a very long time. And I've seen students do this throughout my entire career doing CNA training. You watch me, you listen to me, we review this. You now are kind of rolling your eyes because it's class 3. You've seen this 3 times now. We're not done yet. You will get more reviews. And by the time we get to the part where you're able to practice, which will be next week, you're over this. You're like totally over this. And you get up to start practicing and you don't do your opening and you don't do your, you just kind of do the steps in the middle when you're practicing. You know what's going to happen during the exam? Yeah, you're going to forget. Yep. You're going to be so nervous and you're not used to doing the opening because you rolled your eyes that you won't do them. And you've just lost out on half of your checkpoints. It doesn't matter what a perfect job you did making that bed. You failed the skill because you didn't do these things. So when you're practicing, the best piece of advice I can give you is to practice the whole skill. It's not the opening, the skill, the closing. The skill is the opening, skill, closing. All of it. You have to practice all of it together. Good? It's the best piece of advice I can give you. About 10 years ago, we had a student. I was not worried about her at all. I mean, she had this. She was, I mean, just like on top of stuff. But she practiced without gloves. She practiced in the classroom without gloves. She didn't want to put them on. She didn't want to use the resources. She practiced at home without gloves. And during the test, she did mouth care without gloves because to her, it felt normal. Right? Her brain didn't trigger that, oh my gosh, I'm putting my hand near somebody's saliva without an extra covering. It didn't, there were no red lights in her brain going, wait, stop, we're missing something. Because the way you practice is the way you're going to test. And she ended up failing the test and she came to me in tears and said, oh my gosh, I can't believe that I forgot to do that. So be careful. The way you practice is the way you will perform for the test. Okay. All right. So always make sure that you have clean hands when you touch that patient. We also learned when to wear gloves. Now, you're not going to wear gloves for every skill for the test. If you try to, they're actually going to stop you and say, you don't need gloves for that skill. If you're taking a pulse on somebody and their skin is intact, if you try to put on a set of gloves, those evaluators are going to say, you don't need gloves for that. They're going to stop you because that's an extra expense that they don't need to incur, right? Those testing centers have to pay for all of your supplies. So it also shows a lack of awareness of infection control principles. And we don't want healthcare workers that don't understand infection control. That's just a basic, right? So if you try to use gloves for something you don't need gloves for, you're going to be told, don't wear gloves for that. You have to know when glove use is appropriate. So when should we wear gloves? When we're touching body fluids, personal skin, and non-intact skin. Very good. So that would fall under non-intact skin. Yep. So any rash, any sores, any incisions, if the skin isn't like this, intact, what we're going to call normal, right? The skin isn't fully intact, then yes, we need some gloves. Absolutely. And that applies for the test too. So for the test, if you're going to do a pulse on him and he's got a brand new kitten and he's got all kinds of scratches on his hand from his brand new kitten, would you need gloves? Yes. So remember on class 1, I told you those evaluators are going to check you in and then disappear for a little while. And then they're going to come back and pair you up with somebody else. Well, that's one of the things that they're doing. The evaluator is going to try really hard not to pair you up with somebody that has a lot of cat scratches on their hand or puppy scratches on their hand. If you've got pulse, they would pick somebody else to pair you up with. Now, that person might be just fine for ambulate or feeding or mouth care, but we're probably not going to do anything with the hands. They're going to try to make this as easy as possible. Remember, entry level. The bar is way down here, kindergarten. Okay, no curveballs. Good, good. All right, so if we're going to touch body fluids, non-intact skin, or personal skin, we need some gloves. If we're going to wear gloves, what's the first thing they should touch? The patient. You've got to keep your gloves clean for the patient. Once you've got those gloves on and you've touched the patient with them, are they clean or dirty? Dirty. So now we've got to pay attention to what else we're touching in the environment with those soil gloves so we're not cross-contaminating. Do you think that I should touch this sheet with soil gloves? It's going to go right up next to her face? No. So we've got to pay attention to those things. What else have your soiled gloves touched? And then we need to know how to remove those gloves correctly. So we're going to go underneath, or I'm sorry, we're going to pinch up, glove can touch glove, and then we're going to go underneath on the second one. So pinch up underneath. We also learned about barriers. So we're going to use a barrier anytime we use supplies, and we have to have a place to put those supplies. So the barrier is going to provide a clean place to put our clean supplies. Barrier's all about clean. We can only touch our supplies with clean hands. Again, all about clean. We don't want the supplies to touch our uniform. Why? Yeah, our uniform is dirty. So let me talk about that real quick. This is something that most people don't know. This is something a lot of healthcare workers don't know. I actually gave a talk on this at a presentation or a conference that I went to. So have you guys ever gone to a grocery store or a big box store somewhere and you saw somebody walking around in scrubs? Okay. All right. So now I'm guilty of this, right? On my way home, I might stop at Publix and grab coffee for tomorrow morning or something that I need. Now, I am in scrubs. I am not in clinical settings. So I'm in scrubs. So you might see me out in Publix on my way home and think, oh my gosh, she's in scrubs. Those scrubs are not clean, but I'm not really in that kind of an environment. But if you are in that kind of environment, if you are working in a clinical setting, and we know our uniform is not clean, should we be stopping at local establishments in unclean clothing? No. You'll see it all the time, though, because we kind of lack this awareness, right? We think that once we clock out, we leave all of the germs there. We don't. We take them with us. This is something to be a little bit aware of. Okay. Now, how many guys, I owned a scrub shop. Okay. And one of the things that we sold were scrub jackets. Everybody familiar with scrub jackets? They go over. All right. That's actually what a scrub jacket is supposed to be used for. It's not a fashion statement. It's not to keep you warm in a clinical setting. A scrub jacket should never be in a clinical setting. It should be worn when you leave the clinical setting to cover up your soiled scrubs if you have to go somewhere else. Make sense? Now, on the other hand, we have lab coats. So we have scrub jackets that are meant to cover scrubs. And then we have lab coats that are usually worn by doctors or nurse practitioners or people that are looking to go into a facility for a short amount of time, but they're wearing their normal clothing. So a lab coat goes on when you go into a setting to protect your normal clothes and gets removed when you leave. So if you're in that setting all the time, scrub jacket when you leave. If you're just going in for a quick consultation, lab jacket while you're there. Do you guys see why those outer garments might be important for infection control? Now, a million years ago, when I was a brand new baby nurse, I mean, a million years ago, I worked with HIV positive patients. Now, this is back in the early 90s when we still didn't know a whole lot about HIV. There was a lot of fear around it. And we know that our uniform is not clean once we start working, right? So when I worked with these patients, I had little children in daycare. And I trained my kids, don't run up and hug mommy when I pick you up. If I'm wearing scrubs, don't hug mommy. And as soon as I got home, I would strip before I ever went into the house and put my clothes in the washer. So I did not bring pathogens into my living environment. Now, when you're working with pathogens, and we're not like when COVID showed up, right? We didn't really know exactly how COVID was spread yet. We had to study it a little bit. So those are good precautions to take. A million years ago, hospitals used to have locker rooms, changing rooms with showers.
They don't have that anymore.
They don't. Well, they have them in surgery, but that's it. But it used to be that the regular nurses would wear regular clothes into the hospital, change while they're there, wear their uniform, and then before they left, they would take that uniform off, go back into their regular clothes, shower if they, felt that they need to. But it was a way of restricting pathogen transfer from the clinical setting to the outside world. Well, the hospitals realized they could make a whole lot more money with that space. So they quit doing that. So when I work clinical work, I always have what we call it a go bag. I always have a go bag in my car. In fact, I just stopped carrying one about 3 years ago. I always had a go bag in my car. It had a change of clothes, a change of shoes, because you never know what you're going to step in, shoe covers, and personal protective equipment, gloves, mask, that type of thing, because you never know what you're going to need. Always had a go bag in the back of my car. And if you're going to go into healthcare, these are good principles to kind of be aware of, right? But it all goes back to this. This is our foundation for all of that. Your uniform is not clean once you start working. Pretty cool, right? Pretty cool. Different way of looking at things. All right. If we're going to use a barrier, we get it first before we get the rest of our supplies. That way we have 2 hands to be able to unfold it, then go get the rest of your supplies. And for the test, your supplies will be within, a couple of feet of your page. That's okay. Oh, thank you. Yeah, I got it. A couple of feet of your working environment for the test. Okay. Good. All right. We also learned about privacy blankets. Remember, the principles are not going to be on your care plan. Nobody's going to tell you on your care plan to do the opening or to use a privacy blanket or to use a barrier. This is stuff that's not on your care plan. So we read the care plan and we have to know these things. So we use a privacy blanket anytime the patient's going to be uncovered or undressed. It's used for temperature. So right now in here, I'm standing up, I'm fully clothed, and I'm talking, and I'm getting a little warm. You guys are all sitting over there shivering. And I'm like, can we turn that down a little bit? Because it's getting a little warm in here. Remember that your perception of temperature and your patients are always going to be different. So we can't rely on how comfortable we are to know how comfortable they are. Good? Make sense? So anytime your patient's uncovered or undressed, they're going to be used to keep the patient warm and provide privacy. Privacy curtain is not enough. You're the stranger in the room with them. When we put a blanket on, we don't snap it or shake it. We lay it over the sheet and then pull that sheet down underneath. Snapping or shaking puts pathogens into the air that you can breathe in. And then when you're using a privacy blanket, we have to talk about when to take it off. Now, if the patient asks for it to stay on, no problem. No problem. And a lot of times they will. When I was in the hospital with my mom after surgery, she could not get warm. And anesthesia kind of has that effect on you. And she was freezing. So they've got her in a bed. They got the sheet on. I asked for a warm blanket. I put it on top of her and she's still shivering. So I go get another blanket and put it on top of her. And then I got another blanket and put it on. And she looked like there was an old fable, like the Princess and the Pea, right? So she's buried under all of this stuff. And eventually she did finally warm up as the anesthesia wore off. But of course, comfort is going to be important. But for the test, we're going to take those blankets away. Our patient isn't going to need them. So we have to talk about when to take them away. You've got to take your gloves off before you take that blanket off of the patient, because you have to have the patient covered at all times. We're not going to take that blanket away, leaving them uncovered. We have to pull that sheet up as we take the blanket off. When we pull that sheet up, you can't touch that sheet with dirty gloves. So we have to take our gloves off for this. Make sense? Infection control. Good. All right. So just remember that with privacy blankets and gloves don't go together. Those two things should not go together. We put our privacy blanket on before we put our gloves on, and we take it off after we take our gloves off. You should not be handling the privacy blanket with gloves. Okay.
If you're like working and you're doing that, if it was already there before you entered the room, you just treat it dirty.
Well, yeah, that's going to kind of be on a case-by-case basis, to be honest with you. So let's go with my mom. Okay, let's just use that scenario. But remember, every scenario is different. Okay, but let's just go with that one. So after surgery, she's cold. She's now got 3 privacy blankets on her. Somebody comes in to do a skill. Actually, they came in to check her bandage is what they came in for. So she's buried in 3 privacy blankets and a sheet. Well, they've got to move that in order to visualize the wound and look at the drainage. So as they're moving that privacy blanket, they're asking her, do you really want all of these blankets on? And the first couple times she's like, yes, I'm freezing. Leave me alone. I'm good. But after a while, she's like, yeah, can you take one of the blankets off? I'm getting a little warm. So as they left, they took one of the blankets and put it in dirty linen. So a lot of that's going to depend on your patient and the setting and the condition. And there's a lot of variables there. Okay, good. All right. We also learned a little bit about linen rules. Oh, okay. All right. Yeah, remind me of your first name. Sydney. I thought so. I was right there. I was right. Okay, so 90 on the first. Perfect. Thank you so much. All right, a lot of linen rules are repeats of what we've already gone over, right? Linens can't touch your uniform. We already know that. You have to have clean hands to get your linens. We already know that. We don't snap or shake linens. We already know that. Those are all repeats of things that we've heard before. We're going to skip 2. We're going to come back to those a little bit later. And the last one is we always discard anything we don't use. You can't leave something in the room until later and expect it to be clean. If it's out of your sight, it's not clean. So anything unused gets discarded. That is most likely to be a written test question. You are performing hand and nail care and you take 4 washcloths in by accident. What do you do with the leftover washcloths after the skill is complete? That's right. So the answers would be put it in soiled linen, save them for later, use them on the roommate, or return them to clean linen. Okay, those would be the answer choices. All right, we'll cover the rest of those later. And then we learned the closing. The closing is done at the end of every single skill. There's lots of steps to the closing, but we don't care what order you do them in, except for the last 2. So we're going to make sure the patient's in a clean and safe environment. So take a look around, make sure that the barrier isn't on the table, that the sheet is arranged nicely, that there's no trash on the floor. Look around, neat and clean environment. And part of that is to make sure the bed is in the low position. We're going to talk a little bit more about that today. I think today, maybe Wednesday. Bed in the low position. They need to hear this word. Are you comfortable? They need to hear the word. Part of comfort, though, is emotional. So we're going to address preferences as well. Would you like a magazine, crossword puzzle book, TV remote, something like that? We're going to ensure they're covered with a sheet or clothing. No knobby knees. We're going to open that privacy curtain. And for the test, there's no curveballs here. Just open the curtain. You'll give them their call light. I like to give them instructions too, because I don't know how medicated they are. Give them that call light. And then we wash our hands. Remember, our skill checklist says to end skill with clean hands. So hand washing is the last thing we do, period, end of discussion. So that means that if we have to document, documenting became our last step. Is that right? No. So we have to wash our hands after. Because remember, wash your hands is our last step. Great job. Don't return to the patient. If you realize you're over there washing your hands, right? And you realize, oh no, I forgot to give them the call light, and you have to go back to that patient, it's just like you never washed your hands. You got to wash them again.
You have to do the knock again.
You don't have, no, you don't, you can just go back and give them the call light. But the biggest thing to remember is just try to get all of that done before you find yourself at the sink. Mm-hmm.
When you give them the call light, though, you tell them to just press the red button and then help with the way. Do you come back if they press the red button?
Yes. Yes. Yeah. If you're in the room, so the call light's really, so let's think about the call light for a second. Okay. If I'm here in this patient environment and she needs help and she knows that I'm here and she needs help, what is she going to do? Yeah, she's going to call me verbally. Hey, while you're here, or hey, I don't feel right, or hey, she's going to verbally talk to me while I'm here. The call light is for when I'm down the hall. Does that make sense? Nobody's going to hit a call light to get somebody that's already in the room. Have you ever been sick? Think about when you were a kid, right? And you were sick and you were in your room sick. If your mom is in the house and you're in your room sick, you're screaming for mom. Mom, come help, mom, right? It takes a lot of effort. And when you're sick, you don't always have that kind of energy. So it would be easier if you had a bell to hit, that when you hit the bell, mom would come running. Man, wouldn't that be nice? I want a mom bell. Right? It'd be nice. You hit a bell, mom comes running. That's all a call light is. Except instead of mom, it's a caregiver.
Yeah, I asked because it says do not return to the patient, but normally they press the red button.
Yeah, well, when I say don't return to the patient, I mean get all of that done before you wash your hands. Don't go don't wash your hands and then open the curtain and give the patient the call light and all of that. Okay. All right. Yeah, you can return to the patient if they need you, but not because of the closing. Good. So there's a couple of videos out there that it's another nurse that does demonstration videos. And you'll probably, if you are on YouTube watching demonstration videos, you'll see it. But almost all of her videos, she gives the patient the call light. Like she does her opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to whatever. Is that okay? Here's your call light. I'm going to go wash my hands. And I'm like, it doesn't make any sense. You're in the room. They don't need the call light while you're there. They need the call light when you go. But what's that? It can get in the way of what you're doing. But let's think about our opening for a second. We have to have what kind of hands? Clean hands. If we're handing the patient the call light before we go wash our hands, did we get that checkpoint? Does that make sense? So every time I see that, I'm like, oh, that's not the right order. The call light's at the closing, not the opening. So it just, you're teaching students the bad habits that might get them into trouble. Call lights are for when we're not in the room. If we're in the room, they don't need a call light to get help. Something else about call lights, though, that I find kind of interesting, call lights are not for CNAs to get help either. So sometimes if we're in the room and we need the nurse, CNAs will hit the call light. In the nursing sphere, right, all the people that are in the area, the ones that are answering the call lights are the CNAs. Nurses generally don't answer call lights. CNAs do. So if a CNA is in the room and they're hitting the call light and they're the ones that answer the call light, you're probably not going to get a whole lot of help because you're already there. So what do? If we are in the room and we need help, that call light isn't there to help you. You're going to have to verbally yell for help. But don't use the word help. In healthcare, we don't use that word. We yell staff. I need a staff member in here. Because patients will often yell help. What we want to do is indicate there is a problem with a staff member that needs help, not a patient. Does that make sense? So let's say we have a patient that becomes combative all of a sudden. That call light isn't going to help you. What you want to yell is, I need staff in here now, loudly, like as loud as you can, and people will come help. Now, in a code situation, now this is in a hospital. Some nursing homes this works at, but very few. But especially in a hospital, if you go to work in a hospital, and you are working with a patient and their heart stops and we have to start CPR, again, that call light isn't going to help you a bit. Hitting that call light, that's not going to help you. You got to let people know that, hey, I'm getting ready to start CPR here. I need some help. Need help, right? Yelling that, you're out of breath because you're breathing for the patient. You're doing CPR. You're not going to be able to yell that. Pull the call light out of the wall. Where the call light enters the wall, it's like a little pluggy thing. I could show you on here. It looks like a jack for old-fashioned headphones, right? Pull that out of the wall. When you do that, it automatically triggers a code blue. Yeah. So that's a great way of getting somebody to show up immediately, is to pull. So if you're in a combative situation, even if it's not a code blue, pull that call light out of the wall. You'll get staff members in there. And that's what you need. Good. Okay. So call lights are for patients to call staff members when they're not in the room. Call lights can be pulled from the wall by staff members to trigger other staff members to come. But CNAs are the ones that usually answer call lights. Good. I'm going to have a whole game show on call lights coming up in the future. And probably uniforms too. All right, so we also learned how to take a pulse. A pulse is how many times the heart beats over 1 minute. You don't always have to count for a minute, but the measurement is always 1 minute. So if you count by 15 seconds, we have to multiply that by 4 to get our minute reading. Normal is between 60 and 100. Radial pulse is at the very top part of the wrist. We use our fingertips, not the flat part. Fingertips, never your thumb. You'll put your fingertips in place, thumb on the back to hold consistent pressure, and you count what you feel for 1 full minute. Normal is 60 to 100. Make sure you document. This is a documentation skill. In Florida, if there's 2 evaluators, you have to count with both because they have to grade you independently. Follow their directions. They'll give you directions. Follow those directions. Okay, good. All right. We learned how to dress a resident. When we're dressing a resident, we want to ask them what they want to wear. They have the right to choose their own clothing. And we want to get that clothing before we undress them. You want to minimize the amount of time they're undressed. We're going to use a privacy blanket for this skill so that we maximize privacy and dignity. We lift from below with a flat palm supporting the joints as we dress them. We don't overextend or force movement. And we use USA first to tell us how to do this. So we undress strong arm first, dress weak arm first. That way the weaker arm doesn't have to move a whole lot. Adjust the clothing at the end, make them look good. Everything dirty goes in the hamper, not on the floor. Nothing ever goes on the floor. And we want to put the call light in the stronger hand. We did not learn range of motion. We're going to come back to that a little bit later. So this is a recap of where we're at now. We've learned skill rules. We learned the opening. We learned glove rules. We learned the barrier. We learned privacy blanket. We learned most of linen rules and the closing. So this is what we have left to learn for principles. We're only 1 week in. I still have 3 weeks to go with you guys. And look how far we've come. Has it been too hard? Overwhelming for anybody? A little bit? It's a lot, I know. All right, if you're finding it a little bit difficult, a little bit a lot, remember that online course is there for you. That online course takes everything that I've told you and breaks it down into small bite-sized pieces with activities to help you put it into practice as you're learning it. Right now, learning is only one way. I'm preaching, you're listening. That's it. One way. You got to have a way of getting involved in the learning, and that's what that online course is going to help you do. You've got those drag and drop activities. You've got some flashcards in there. You've got all kinds of things to help put you in the learning part of this.
You see how for the skill assessment, they make you do 5 random ones, 5 or 3?
So it's 3 skills, right? 3 random. So here. So there's 11 sets. Okay. Each set has 3 skills. 1, 2, 3.
How many skills are in total?
Total are 21, including hand washing. So everybody has hand washing because we wash our hands before and after every skill, right? We know that. So really there's 20 physical skills we have to learn. So that's what's going to make these cards up. These are a combination of 3 out of that 20. You will do 3. Now, I'm very specific in how I answer this. Your care plan sets have 3 skills. These are the 3 skills you are going to be graded on, but you're actually getting scored on 5. So you have these 3 plus hand washing plus indirect care. Now, we talked a little bit about indirect care at the very end of class 1 for like 2 minutes. Indirect care is going to be all the nice things, promoting dignity, knocking before you enter, your facial expression, your tone of voice, how fast you talk to the patient, how involved you get them in the skill. And the test really wants to see, are you doing things on somebody or are you doing things with somebody? There's a big difference there. And that's one of the things that they're going to be looking at. So that's called indirect care. So you have these 3 skills plus hand washing plus indirect care that you're going to be receiving scores for. Okay. So the answer to that is yes, there are 5 skills, but 3 clinical skills. I know it's a little confusing. Any other questions? Sure. Absolutely.
We're in the middle of class.
Absolutely. I'm going to pull up a chair because my knee is killing me today. All right. Any other questions before we move on? Yep. Jacob will be happy to help you with that. The flashcards have all of these principles that we went over, has all the supplies for each skill, and the short steps for each skill as well. So you see that gray box up in the corner? That gray box are what we call the short steps. You get those for every skill as well. So the step-by-step, so for instance here, if you go to page 117, you'll see all of the steps for this skill. Like everything is listed. Everything from knock, enter the room, identify the patient, say your name and your title. I mean, everything is listed there. Very detailed. Just the steps, yep. There isn't much vocab on the state exam. They don't really care if you know what a decubitus ulcer is. Because in a clinical setting, if you don't know what something is, what are you supposed to do? Ask. Absolutely. CNAs are not judged on your knowledge. You're judged on what you do. So most of the test, go ahead. No, you're good. Most of the test is going to be based on CNA principles, not vocabulary. And a lot of people get really kind of tied up in medical abbreviations and vocabulary and terminology, anatomy and physiology, and they study all this stuff that has nothing to do with the test. Yeah. So we do have in your book, you do have vocabulary words from each chapter at the bottom of your chapter tests that you're taking. Those are all vocabulary words to get you familiar with them. But in a clinical setting, if you don't know what something means, ask. There's a explanation I give on this usually in class 6, but let me give it to you now just so you kind of understand what I'm talking about. If you don't know what a term means, if you aren't 100% sure, don't make up something. So years and years ago, you know, I had the scrub shop and we got people from all over, from Tampa, all over. Well, we had a woman who lived here but worked down in Tampa, and I'm going to, for the sake of this, call her Kathy. And Kathy worked in the cardiac cath lab. And she came in one day and she said, "You still teach, right?" And I said, "Yeah." She says, "I've got a story for you." Okay. She said, it's like 4:30, 5 o'clock in the morning. She goes upstairs to get a patient for a cardiac cath. And when she walks in the patient's room, he's sitting up in bed eating. Now, he's not supposed to have anything to eat or drink before this procedure. And she goes out. Well, she asks the patient, "What are you doing? You're about to have a cardiac cath. Why are you eating?" And the patient says, this is how it was relayed to me. Okay, I'm just passing this on. Patient says, "Yeah, I know. I thought that I wasn't supposed to eat or drink, but the nurse brought this tray in and said I had to have it before you came." So she's like, okay. So she walks out, finds the nurse and says, what's going on? Why is the patient eating? Nurse says, I don't know. There's a student with that patient. Let me go find the student. So they go together. They find the nursing student. Now, this is a nursing student. This is the conversation that Kathy relayed to me. Okay. I'm going to play both parts. This is the conversation. Kathy, to the student, the patient is having a cardiac cath. Why are they eating? Student, because they're NPO. Kathy, I know they're NPO. Why are they eating? Student, because they're NPO. Kathy, what do you think NPO means? Student, bananas, pineapples, and oranges. I went and had the tray made special myself. True story. This is a nursing student that did not know what NPO meant. NPO means nothing by mouth. It doesn't mean anything in English because it's abbreviated from Latin words. But she didn't know what NPO meant. And instead of asking, which is the ethical thing to do here, we don't expect you to know everything. We don't expect nurses to know everything. But we do expect you to be ethical enough to admit that you don't know and ask. Instead, she made up something in her own mind that somehow made sense to her. Doesn't make sense to anybody else because nanas isn't even a word. So now we've got a patient who needed a cardiac cath who cannot have one. We have a cardiologist in the cath lab, all scrubbed in, ready to do this procedure that can't do it. We have all of these supplies that we put out and unpacked for this specific case that now have to be scrapped. This is a tremendous cost, not just financial, but also to the patient's well-being and future health, all because somebody made up a word. Does that make sense? You as a CNA are not expected to know medical terminology or medical abbreviations. You are expected to ask if you don't know what something is. Now, in my book, on page, hold on, I have it here, 131, I have a whole list of common medical abbreviations. Page 131 talks to you about the medical abbreviations. 132 lists them. 133 is an activity that puts it into practice. And this is a great way for you to get familiar with a lot of these terms that you're going to be using in healthcare. But the test is not about medical terminology. Now, anything that is highlighted in the gray, like QH, I's and O's, NPO, those are ones that you're, there's a possibility you may see them on the state exam, but they're not going to ask you, what does NPO mean? It'll say your patient has an NPO order. Which of the following could you offer them as a snack? Okay, nothing, ice chips, Jell-O, or a tuna sandwich? Nothing. So do you see how it's different? They're not asking you what is NPO. They're not asking you to define it. They know that you need that information to be able to answer the question. It's a little bit different way of presenting the information. Make sense? Good? All right. So the going back to the flashcards, Once you have done a skill, like on page 117 is our step-by-step, every detail. Once you've done a skill once or twice, or you've seen it done once or twice, you don't need all of those steps because the opening covers the first 7 steps, right? The closing covers the last 6 steps or whatever. So what you need is just the short version. And that's what that gray box is. Good? Questions? All right, so we are going to learn how to perform hand and nail care. Hand and nail care on page 116, this is our overview. If you look down the side, you'll see all of the principles that are involved. So skill rules, the opening, glove rules, we need a barrier. Good morning. We're going to be working with linens. Yeah, there's still chairs. We're going to be working with linens. And then we have washing rules, basin cleaning that we don't know yet. So that's where we're going to start today, is learning another principle, which will be washing rules. Page 117 is our step-by-step instructions, has our care plan at the very top of the page, has our supplies at the bottom of the page. You have to learn your supplies, guys. And we have flashcards to help you with that. Remember, the flashcards have all of the supplies on them. At the beginning of the videos that we show you, you'll actually see the flashcard for that particular skill. So if you want to make your own, watch the video, pause it, and just copy it. Or you can buy mine for $15, which might be a little easier. But supplies, principles, and steps. The flashcards have all of them. Let's see here. So here's our care plan for this skill. It says provide hand and nail care to one hand. The resident is sitting in a chair at the bedside and can move as directed. So let me explain to you what hand care is and what it isn't. We do hand care usually once a week on long-term care patients. This isn't something generally that's done in the hospital. This is generally done with long-term care. And what we're doing here is trying to keep the fingernails at a manageable length so we never have to trim them. A little bit of preventative maintenance keeps us from having to do big maintenance. Make sense? So if we soak a hand, wash a hand, rinse a hand, dry a hand, clean under the nails to get any debris out, and then file the nails. If you do that once a week, you never have to trim the nails because filing is keeping them at a manageable length, keeping them smooth so they're not no jagged edges, they don't injure skin, nothing like that. It's preventative. CNAs do not use nail clippers. Nail clippers are advanced pieces of medical machinery we're not allowed to use, period. We file on a regular basis instead. That's what hand and nail care is all about. It's a mini mani. You're going to soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, file the rough edges, put a little lotion on because everybody can use a little lotion. Wipe off the excess and that's it. That's the whole skill. It's not a bad skill to get, but it is a washing skill. So we've got some rules we have to learn here. Okay, good? All right. So let's start with washing rules. These rules, washing rules, are going to apply to hand and nail care, foot care, partial bed bath, peri care, and catheter care. So if we got 20 skills to learn, this is going to apply to a quarter of them. We do a lot of washing. So there's some rules that we have to follow here for this. The notes for this will be on page 113, so you can follow along. Remember, I took the notes for you. But we have to think about how we bathe. So when you bathe, you do these steps without ever thinking about it. You just do them because it's just part of your routine. But you get into a shower and you get wet. After you get wet, you put soap on. What do you do after you put soap on? You rinse it. How weird would it be to get all soaped up, shampoo in your hair, and then get out of the shower? That's like really weird. You would not feel done. Believe it or not, rinsing is the one step, bless you, that is missed on the state exam more often than any other. Because we tend to, you wouldn't do this to yourself, but the problem is you don't think about it. You're just in the shower doing the steps and your mind is on something else. When we're washing somebody else, we have to think about it. We actually have to think through the steps. And the way we're going to do that is to use a very simple little sing-song. Whatever I wash, I rinse. Whatever I rinse, I dry. You're going to hear me say that a lot in this class. Whatever I wash, I rinse. Whatever I rinse, I dry. Now, if you do that, if you take my advice and do that, when you're washing, you're saying to yourself, whatever I wash, I rinse, you will automatically go to that next step. If you don't, you will go from washing to drying. You'll skip rinsing. I don't know why. It just is. So whatever I wash, I rinse. Whatever I rinse, I dry. If you can remember that as we go through these skills, you'll stay on track. But here's the problem. In a shower, that's easy. We have water coming from the sky. We get wet, we wash, we rinse. Water's right there. When we are doing these skills on a human that is not in a shower, rinsing becomes something else. Water is not coming from the sky. We have to have rinsing water. Okay. The reason that this rule right here is so important is because if we add soap to our basin, we have no rinsing water. Whatever I wash, I rinse. Whatever I rinse, I dry. We have to have water for rinsing. If we put soap in the basin, we have no rinsing water. So our rule here is basins are no soap zones. We don't put soap in the basin. Now, some of you are going to go, but wait, why can't we just use two basins? One to put soap in and one for rinsing. Well, you could, but you've got enough to do. Like really, you've got way more to do on a daily basis than you can possibly get done. And by using two basins, you are now doubling your cleanup. You can't throw these basins away. That's an extreme expense for your patients. Each one of those basins has to be scanned out and charged to that patient. Every time you get supplies for the patient, we charge them. Anybody ever go to the hospital? Did you get a bill? You know what's on that bill? Everything. Now, when they send you the bill, they don't itemize it. They just send you a bill. You owe $3,250, cash or check, right? They don't give you any options. But you could ask for an itemized bill. And they have to list everything that they used on you. Medications, IV fluids, surgeries, basins, toothbrushes, cups, everything that got scanned out gets charged to you. Now, those basins average about $35 a piece. which to me is absolutely ridiculous because you can go to the Dollar Tree and get one for $1.25. But if they came through the hospital, there's going to be a markup. So if you throw that basin away, you've just thrown away $35 of your patient's money. It's crazy. And they have to pay that. And if they don't pay it, they will take, the hospital will take them to court. So to me, this is kind of like, how many guys ever go out to dinner? So this is kind of what it's like, right? You go to a restaurant, they don't have menus. They look at you and go, yeah, I know what you need. You don't get to order. I'm going to bring you what I think you need. And you're like, okay, but how much does that cost? Because I'm ordering off the menu based on what I can afford. And they go, yeah, don't worry about that either. So we're going to give you what we think you want, and we're not going to tell you how much we're going to charge you for it, but you have to pay the bill when you leave or you're getting arrested. How many of you guys would go back to that restaurant? You don't get to pick your food. You don't get to pick your price. And if you don't pay, there's a consequence. That's healthcare. Because we're the ones that get most of the items our patients use, we have to be aware of this. We are the ones that add to that bill more than anybody else. Make sense? So don't use 2 basins. It's an unnecessary expense for your patient. But it's also something else that you have to clean. You don't have time for that. Cleaning 1 basin is bad enough. Okay, good. So we get water in our basin. We don't add soap to it. And now we have water for rinsing. Solves all problems. What we're going to do is wet the washcloth, wring it out really well. No drippy wet washcloths. Wring it out really well and add soap to the washcloth. Do you think that soapy washcloth goes back in the basin? Because we need clean water for rinsing. Make sense? Good? All right, so basins are no soap zones. So whatever we wash, we rinse. Whatever we rinse, we dry. And since we have to rinse the soap off the skin, we don't add soap to the basin, and that keeps our water clean for rinsing. All right. Now let's talk about how to get that water. We've done our opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care on your hand. Is that okay? Close curtain, wash hands. My hands are now clean. I'm going to go to my shelving unit. I'm going to get a barrier, put it on my table. I'm going to go back and get everything else I need. So I'm going to get my 2 washcloths, my towel, my emery board, my orange stick, my basin, my soap, and my lotion. I'm going to put them all out on my table. Pair of gloves if I need them, like if my patient has a sore or open skin or something like that and I need them. If my patient's skin is intact, do I need gloves? No. So I'm going to get everything, put it on my table. And now I'm ready to go get water. So the only things my clean hands have touched is the clean supplies. Good? So I get my basin. I take it to the sink, and I've got to fill it up with water. Is that sink faucet clean? No. But my hands are. So what could I use between my hands and that sink faucet to turn the water on to keep from contaminating? A paper towel. Yeah, anything. A barrier of some sort. But there's paper towels right there next to the sink, so let's use those. I'm going to grab a paper towel and turn the faucet on. Good? Good? All right. Okay, so we're going to use a paper towel to turn that faucet on. Once the water is running, we want to feel it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. And this is the area I want to feel it with, because this is the thinnest skin I have. It's going to be the most effective way of gauging water temperature. If I use this part, I've got a lot of fat and not very many nerve endings here. So this water is going to feel different than this water. Good? Okay, so let me explain why this is important. We want our patient to check the water temperature too. We think it's comfortable. They may not agree, and this is why. As we age, the layers of our skin, our fat, and our muscle shrink. They shrink down. Have you ever seen an old person's hand? Kind of looks like this, right? We have these veins running underneath the skin. They look like big ropes. And it looks like a layer of tissue over these blood vessels. Now, mine does not look like that. Yours does not look like that. So we know that somewhere in this aging process, we go from young and healthy to old. We have changes. Make sense? So what is this change? Well, this change is your skin layer gets way thinner. Your skin becomes like paper thin. But the layer of fat underneath that layer of skin actually goes away in the extremities. It like disappears. And the muscle itself shrinks. So we have these layers that were pretty thick and now they're really thin. Why do we care about that? Well, that layer of fat that is now no longer there did several things. And now that it's missing, we have to talk about what kind of effect that has on the patient. So what does that layer of fat do? Insulation is a big part of it. Do you guys know what body temperature is? 98.6. It's usually a range, 97.6, 99.6, somewhere in that range. But let's just stick to 98.6. That's kind of what we know as the baseline. Most people are about 98.6 degrees. What temperature do you think it is in this room?
78, 72.
All right. Let's use an easy number. I like easy numbers. Let's just say 75. Okay. So if we have 98.6 degree humans and 75 degree air, that's a big difference. If this room were 98.6 degrees, how would you describe it? Hot, unbearable. I mean, if it gets up to 80, people are like, okay, this is too much, right? 98.6, way too hot. And yet all of you right now are running at 98.6 degrees. You ever stop to think about that? You are hotter than your environment. This is why when you put a whole bunch of people together, the place heats up because of body heat. Good? Makes sense? Why do we care? Well, in order to keep your body at 98.6 degrees, your body has to burn calories. The whole purpose of you eating, aside from nutrition, is to keep your body at 98.6 degrees. Because room temperature always wins. Room temperature always wins. If I baked a pie at 325 degrees, put it in the oven, let it bake for an hour, took it out of the oven, that pie is 325 degrees. If I put it on top of my stove and leave it there for hours, is that pie still going to be 325 degrees? No, it cools down to room temperature. Whatever that room temperature is, that pie will cool down to, because room temperature always wins. Now, pie goes with ice cream. If I pulled ice cream out of the freezer, that ice cream is about 0 degrees roughly. Pull it out of the freezer, put it on the counter. Is that ice cream going to stay at 0 degrees? What happens? It warms up to room temperature. Room temperature always wins. Whether we have something that's really hot or really cold, room temperature will equalize it to the environment of the temperature. That is a physics principle. Room temperature always wins, period. Except with humans. Room temperature is trying to cool you down to 75 degrees. That means that in order for you to stay at 98.6, your body has to constantly generate heat to keep you at that temperature. This is an active process. Without it, you would cool down. Now, let me explain to you how critical this temperature variance is. Anything below 95 degrees for a human is incompatible with life. 95 degrees. That's the coldest you can get and still be alive. 93 is dead. So room temperature is trying really hard to get you to 75. You have to be above 95. This is an active process in your body. Your body has to burn calories to generate heat to keep you at this temperature. Good? Makes sense? Okay, room temperature always wins. So we have this layer of fat all along our body that helps hold in the body heat that you're creating. So your body doesn't have to work so hard. That layer of fat is going to keep outside temperatures out and inside temperatures in, so your body doesn't have to work that hard. Now, as we age, if you remember, I told you that layer of fat goes away. So with older individuals, they're not going to be able to maintain a 98.6 degree core temperature very well, because whatever heat their body is making is going to radiate away. Have you ever heard an old person say, "I'm too cold"? They'll be sitting there shivering in a sweater, and you're like, "It's hot. Grandma, it's like 86 degrees in this house. Can we turn out the AC?" This is why. Because they don't have that layer of fat that helps hold their inside temperature in and blocks out the outside temperature. Now, if you remember, room temperature always wins, right? This is why your older people can't live up north anymore. They'll tell you, "I can't handle the cold," because room temperature always wins. Their body has to work so much harder to keep them at a living temperature. So with that loss of fat layer, their ability to regulate their temperature becomes harder. Their body has to work harder. Make sense? But one of the other things that that layer of fat does is it insulates the nerves from outside temperature. So when I still have that layer of fat here, when I put my hand underneath the faucet and I feel that water temperature and it feels fine to me, my patient, when they check that water temperature, may get something totally different because their nerves are not insulated like mine are. So we always bring the water to our patients and ask them, "Can you check the water temperature, please?" And if they say, "Oh, that's too cold," we warm it up. If they say, "Oh, that's too hot," we cool it down. We don't argue with them because they actually have a much truer gauge of the temperature than I do. I'm feeling through a wetsuit. Good. The maddest I've ever gotten at a CNA was over this particular situation. I was sitting at the nurse's station charting, And it was something significant that I was charting. I can't remember whether it was a patient fall or something, but it was something that took a lot of concentration. And I start hearing the screaming from down the hall. So I drop what I'm doing. I go running down the hallway, and it's coming from the shower room. And the first thing I thought is somebody slipped and fell. I open the door, and the steam just comes wafting out at me and fogs up my glasses. I can't see a thing for a few seconds. I walk inside, and I'm like feeling around. What's going on? Everybody okay? And the patient is screaming bloody murder. I mean, just screaming. And my glasses finally cleared enough so that I could see. And the CNA is literally fighting the patient, like trying to push her hands down and push her under the water stream and fighting the patient. And the patient is flailing and screaming. And I'm like, what is going on? I immediately walked over and hit the water, turned the water off, threw a bath blanket over the patient to cover him up. I'm like, what is going on in here? And the patient was absolutely crying. It's too hot. It's too hot. And her skin was all flushed, red. And I'm like, what's happening? And the CNA's like, she's just complaining. The water's fine. I checked it. Okay, first of all, there is steam billowing out of this room. That water is not fine. We are here to help the patient. Help isn't help if it doesn't help. You are doing a skill. You are not helping the patient. There is a big difference between the two. We don't shower people at their detriment. If the patient says it's too hot, what does that mean? So I told the CNA, go outside, we'll talk later. Because I will never yell at you in front of somebody, but God help you when I get you alone. Because that's somebody's mom. That's somebody's grandma. And there is no need for us to do that. None. Your opinion of the water temperature has zero impact on your patient's perception of that temperature. So I finished showering the patient, got her back into her room, got her dressed, got her settled, apologized up and down and sideways. That patient did not want to be showered after that. She refused showers. Why do you think she did that?
She didn't trust any.
Absolutely. She didn't trust. Absolutely. Don't do that. If they say it's too hot, it's too hot. I don't care what your opinion is.
I had a similar situation. 2 years ago, I lived in Denver, Colorado, and I took care of a patient who was 101.
Wow.
She had no issues really. Like she didn't have any problems digestion. She didn't have any COPD or asthma. She didn't have any memory loss or anything like that. She's really healthy. She's 6 foot tall, very healthy in weight. She ate normal food. I cooked her dinner. We sat down at the table. We ate whatever she wanted that day, whether it was steak. She had all of her teeth, everything. She's really healthy. But she had refused showers for the same reason. Her husband had passed when she was 80 years old, and not long after he had passed, she ended up having home health aides come in because she's 80. She's going through a lot, losing her husband and stuff. So she just kind of needed more care and didn't want to be by herself. And her first aide that she ever brought in not only burnt her with the water, but didn't give her the support getting out of the shower, and she fell, and she ended up having to have a hip replacement.
Oh my
She broke her
gosh.
hip. So for when I was taking care of her, she informed me the last 20 years she had never been in a shower. She had bed baths. Because after that shower,
She was traumatized.
She was just traumatized. She didn't want to be under the water. It burnt, the water had burnt her scalp and her back. They didn't check it before or something. So, and she had to have a hip replacement because she didn't have the assistance getting out of the same shower.
Right.
She had been burnt. Her body was weak because it was too hot, and she said her arms were numb from how hot it was and stuff. And the nurse, the CNA didn't give her the assistance getting out of the shower. She slipped, she fell and broke her hip at 80 years old and had to have a hip replacement.
That's
And
horrible.
luckily enough, she was healthy enough to have the hip replacement. But she never took another shower. She just did bed baths and stuff. It was the same reason, the CNA. And she said it was a younger CNA that had just started and kind of just didn't take that into consideration or lay a towel down or make sure there's a mat to get out of the shower. Just
Yeah.
the small things. But yeah, she went 20 years without a regular shower.
Yep.
Because it traumatized her.
And I can absolutely see that. What we do matters, guys. What we do will impact these patients for the rest of their lives.
She was really sweet during her bed baths and stuff. She's an amazing patient.
Oh, I can
worked with
imagine.
her 7 days a week.
Wow.
I worked with her every single night. I was there like holidays and stuff like that. So we did like Thanksgiving and Christmas together. And she was such a sweet lady. She had such a great story, but it was just like she had a lot of. There was other stuff. It wasn't just her shower. It was like she had to do a certain exercise and stuff to make sure she's going and stuff. She didn't leave her. She never like went out of the apartment because she lived in her elderly apartment complex. But like she just had certain rules because she had had home health aides for the last 20 years, and just throughout time it was like, you know, she goes through so many and they're all different. They all have their ways of doing things, and she
Yeah.
had to kind of like set her own boundaries for when she does get new ones, so that way they don't mess up essentially.
Absolutely. Well, I go right back to help isn't help if it doesn't help. And in that case, did that home health aide serve the purpose? No. No.
She lost her license.
She lost her.
Yeah.
After 20 years of quality of life.
Sure. Absolutely.
Yeah, I mean, they also lost her license, but I feel like it just losing your license, you can go get another career, you can, you know, your life goes on and you're fine as a younger person. But yeah, she was terrified of showers, and she never got back in. So
Yeah. Yeah, I've unfortunately seen that. And you're going to see it too on the other side of it. You'll go into shower a patient and they'll refuse. So do you remember what we do when a patient refuses? Ask why, and then what do we do with that information? Report it to the nurse. There is a situation there that the nurse needs to intervene with, because in a lot of cases, you are the next person after the fall. And if that CNA did not report the fall, you're the one that knows about it. So we have to be really careful here to understand our scope of practice. This is why we report everything to the nurse, because there's no guarantee that the nurse knew what happened. But I want to talk about something physiological with this situation, because you brought, bless you, you brought something up that I want to talk about really quickly. When we're talking about showers specifically, showers. When you take a shower and it's hot, because it's full body. Okay, I'm not talking about a basin, although there is an effect with this smaller with a basin, but shower your full body. When the water is hot, heat dilates blood vessels. So, especially arteries. So, when you're in a very hot shower, your arteries go from here to here. That means that your blood pressure, the amount of pressure inside that artery, falls. So when we have an older person who is in a hot shower, their blood pressure plummets. And that sudden low blood pressure, because you have to have pressure to get your blood up against gravity to the brain. So when we have a patient in a hot shower, particularly an older patient in a hot shower, and their blood pressure falls very quickly, they're not getting enough blood to the brain, which is going to affect coordination. So when we're helping them get out of the shower, they're much more likely to fall. That's right. Or they could even pass out from the lack of good blood flow to the brain. This is one of the reasons when we're showering an older individual, it's better to go cooler than hotter. Does that make sense? You got the temperature regulation issue, but you've also got this hemodynamic issue as well. Do you guys have a question?
Just want to tie back into what we were talking about a minute ago.
Yeah.
Inadequate medical care is even starting to affect younger generations.
Mhm.
Over 60% of women who get ovarian cancer, at some point within the last 3 months of finding out they had it, went in for other medical reasons
Mhm.
involving that area. But most times doctors just tell them it's something else.
Yeah. Yeah. Our medical system is not what it used to be. And I've been in medicine long enough to have seen the changes. Yeah. I'm not. Oh, your sister has ovarian cancer? Oh, I'm so sorry.
My
Really?
sister,
So
she had
sorry.
3 kids and she was hospitalized with her youngest 2 throughout her pregnancy and afterwards. And they never said anything. And then she went in because she also has very weak kidneys. So after she had my niece, which is her youngest, she's having problems with her kidneys. And one of her kidneys was essentially just shutting down. And she went into the hospital, and she went to a different town because she was tired of going in for the same thing, and they never did anything. And they went in to check her kidneys, and they ran tests, and then they were like, they had her see a specialist, and she's actually, she has progressive ovarian cancer.
Oh my gosh.
So, and it was missed. She had her first kid pretty young. I mean, she's only 25 now. So, and her oldest kid's like school age. He's in school, so she's had it for a while, and they never saw it. So, I mean, I get it.
Yeah. I'm so sorry. We have to remember that not all of our patients are going to be old.
Yeah.
You know, there's a lot of medical care that will occur to younger patients as well. All right. So when we get water, we check it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. But we're also going to ask our patient to check it, which is probably the most important step here, because what we think really doesn't matter. It's what the patient thinks. If that water gets cold, or if we somehow get soap in the water, from rinsing or whatever, if it's no longer clean water for rinsing, then just change the water in the basin. For the test, you can change the water as often as you need to. If you're doing things quickly, you shouldn't have to ever change that water for the test. But just kind of pay attention. Is the water cold? And you can feel it when you put your hands in it. Is it too cold? All right, so our steps here is whatever we wash, we rinse. Whatever we rinse, we dry. We also don't want to get our surface wet. So this is why we have a barrier on the table, absorbent side facing up, so that we're not getting water dripping on the floor. You're not getting your surface wet. So whatever we wash, we rinse. Whatever we rinse, we dry. Now, this is why we have to rinse. Just like I said, it would feel weird if you got out of the shower with soap on your skin and shampoo in your hair. If that soap dries, this is what it looks like under a microscope. This is itchy. It'll irritate the skin. They'll end up scratching, and it's just not comfortable at all. So rinsing is actually very, very important. And it really surprises me that this is the number one step on washing skills that is missed during the test. So that tells me there's a whole lot of patients out there that are running around with itchy skin and probably don't even know why. So rinsing becomes pretty important. All right. Change the water if it gets cold or soapy. Keep your surfaces dry. And then if we're going to put lotion on, we warm it up first. So put it in your hands, rub it together, warm it up first, wipe the lotion on, and then take a towel and take off the excess lotion. Because when you put lotion on, only so much is going to absorb. Whatever's left is just going to stay on the surface of the skin because it's saturated. Well, if that person goes to pick up a cup of hot coffee and they have lotion on their hands, that cup can slip. and they can end up spilling it on themselves, and hot coffee can burn you. So anytime we put lotion anywhere on the body, we rub it in until it's saturated, and then we just remove the excess. It doesn't need to lay there. Good? All right. So that's washing rules. A lot of rules. Basins are no soap zones. We use a paper towel to turn our faucet on. We're going to check the water. It should feel warm, not hot, not cold. Your patient will check the water. We're going to wash, then rinse, then dry. Keep your surface dry, right, with a barrier. Some of the skills that we're going to learn, the surface we're working on is the table for hand and nail care. But for foot care, it's going to be the floor. So where do you think the barrier needs to be? On the floor. In bed, if we're giving a bed bath, our surface is the bed. So we need to put a towel or something under the patient where we're washing. Keep your surface dry. Good. And then if you're going to put lotion on, warm it up first, wipe off the excess. Those are washing rules. Now, the next principle that we have to learn today is basin cleaning. Now, basin cleaning, all basins are going to be cleaned the same way. It doesn't matter what they are. A bath basin, an emesis basin, which looks like this. This is an emesis basin. A graduate container that you dump urine into. Basically, anything that we put liquid into, we're going to clean the same way. And for the test, that cleaning is simply rinse it, dry it, store it. That's it. We don't have to disinfect it for the test. We don't disinfect anything for the test. We rinse it, we dry it, we put it away. Drying is important though. This drawer is warm and dark. If you don't dry, we're putting moist away in a warm, dark environment. What can grow there? Yeah, and remember, we're not disinfecting. So drying becomes very important. Good. Dry the inside and the outside. But if you are in a setting that requires us to disinfect, we have to know how to do that. For the test, rinse, dry, store. But we have to have a process that allows for disinfection if we need to. So let's talk about basin cleaning that allows for disinfection. So this is going to be located on page 90 of your book. You can see we're going to clean a lot of basins. Look at all of those skills that are going to require basin cleaning. We have bedpan, denture care, catheter care, drainage bag, foot care, hand and nail care, mouth care, partial bed bath, and peri care are all going to require us to clean something. A lot of basin cleaning going on. Our notes are going to start on page 91. But here is basin cleaning. You're going to see this in just a few minutes. You're going to see this in a few minutes. Don't get caught up in the details. You're going to see this a lot throughout the program. If you don't get it this time, you'll get it next time. It's okay. Remember, rinse, dry, store. That's all that's required for the test. They don't even ask about infection control here. Rinse, dry, store. That's all you need to do for the test. But let's talk about how to do this in a way that allows for disinfection. So we're going to dump the contents of the basin wherever it would normally go. When you brush your teeth, where do you brush your teeth? Over the toilet or the sink? Sink. So mouth care can be dumped in the sink, right? When you bathe yourself, do you bathe your feet? Where does that happen? In the shower. Well, we don't have a shower, but we have a sink. So foot care can be dumped in the sink. Doesn't have to be in the toilet. Now, with body fluids like urine, where would that normally go? Would you ever put urine in the sink? Don't start now. Okay, so we're going to put it where it would normally go. If we're dumping body fluids, those go in the toilet. If we're dumping bathing, that goes in the sink. Good? Questions? All right. Once we've dumped the basin, whatever the contents of the basin were, once we've dumped it, now we're going to rinse the basin. Now you're going to dump that rinse water wherever you dump the contents. If you dump the contents in the sink, dump the rinse water in the sink. If you dump the urine in the toilet, dump the rinse water in the toilet. Good? Okay, so we're going to rinse it, dump the rinse water wherever the contents went. This is a principle you need to understand. Basins are only used by that one person. If you go to the hospital, you get an admission kit that has a bath basin, an emesis basin, a water pitcher, a cup. It's all yours and yours alone. We're not sharing that basin with your roommate. That bedpan has nobody else's butt on it but yours. It is yours and yours alone. So we're simply going to rinse, dry, and store because you're the only one that is going to use that item. Okay, good. Good. All right. Now, if disinfection is necessary, so let me explain this really quickly. In most settings, with most patients, rinse, dry, store is all we ever need to do. Think about your sink. You brushed your teeth. You probably did not disinfect that sink after you brushed your teeth. You rinsed the big globs of toothpaste out, if we were lucky. Right? That's all you did. Your toilet, when you sit down on it, you probably don't disinfect it every single time you use it. You disinfect it once a week or when company's coming. Right? All right. But there are certain situations where we do have to disinfect. Like if you get sick and somebody else is going to use that toilet, you probably would disinfect it. If you don't have a good working immune system, like you're on chemotherapy, then we probably want everything disinfected so that you don't get something because we've killed your immune system. Make sense? So if you have a communicable disease, then we probably want to disinfect so you don't spread it around. If you have an affected immune system, we probably want to disinfect it so you don't get something that you don't have already. Make sense? Where would that information be for this patient? The care plan. So if our care plan tells us to disinfect, it's because either the patient has a communicable disease or they have an immune dysregulation. Make sense? In that situation, we would need to disinfect. So the way we do that, we dump, we rinse, we dump. I can't disinfect if I'm holding on to that basin with a dirty glove or a dirty hand. Disinfection means I can't be holding it. So I dump it, I rinse it, I dump it, and I set it down in the sink, hands off. Once I set it down, then I can spray it, not holding it. But I do have to pick it up to dry it. And I don't want my dirty hands to touch the disinfected basin. So I'm going to use a paper towel to pick up that basin. Then I'm going to use a paper towel to dry the inside. Then I'm going to use a paper towel to dry the outside. Different paper towels because you only disinfect the inside, not the outside. And then I have to put that basin back in the cabinet. I still have dirty gloves on, so I need a paper towel to collect my items and open the drawer. Then I can throw my paper towels away. Good? All right, so let's recap that one more time. Remember, we're going to be seeing this a lot as we go through the program. We have a lot of basin cleaning to do. For the test, we're going to dump our basin, rinse it, dump it, and set it down. We're going to use a paper towel to pick it up, paper towel to dry the inside, throw it away, paper towel to dry the outside, throw it away, paper towel to pick up our supplies and open our drawer. Throw the paper towels away. All basin cleaning is done exactly the same for the test. Doesn't matter what it is or what it held. It's all done exactly the same. And for the test, we don't disinfect. We rinse, dry, store. Good? Remember, in a clinical setting, your care plan may tell you to disinfect. You do that when the basin is sitting in the sink. Process exactly the same. Exactly the same. It's just we don't skip the spray when we set it down in the sink. For the test, we don't spray anything. We used to. If you ask me, just me, I think we should. Because who's going to be a patient for the test? Raise your hand if you're going to be a patient for the test. Everybody, right? Every single one of you is going to be a patient for the test. You're going to be a patient. So you're going to spit when you do mouth care, you're going to spit into that basin and somebody's going to clean it and put it back. And the next person is going to have mouth care. You were spitting into that basin. It was never disinfected after she used it. So do I think that they should be disinfected? Yes, I do. Because these are not single patient use for the test. But they quit doing it because some people have a respiratory issue and the spray can cause a respiratory reaction if you have reactive airway disease. So they stopped doing disinfecting. Rinse. Oh, yeah. A lot of the disinfecting sprays now that are used in a clinical setting are liquid based and like kind of like a 409 type thing, right? So you don't have that aerosol spray like Lysol. So it's better to disinfect with a liquid disinfection agent or a hand wipe. I'm in favor of disinfecting hand wipes. I think they can be used quite easily during the test. Nobody asked me. So maybe one day they will. All right. Any questions on washing rules or basin cleaning? You're going to see this a million times. All right. So now let's get into our actual skill here. This is hand and nail care. So if you look at the steps that are left, right, because we have to read our care plan, do our opening, decide if we need gloves, get our barrier, get our linens. We are going to use washing rules, basin cleaning, and the closing, all of those things, right, that we've learned, all the principles. Look how many check marks we get for all of that. We haven't even got to the skill yet. And look at we're 3/4 of the way done with our check marks. Pretty cool. Now let's get into the skill, right? There's only 8 things we need to know about this. So we're going to follow the care plan. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you? I'd like to do hand and nail care on one hand. Is that okay? Close curtain, wash hands. Decide if I need gloves. I might. Maybe the patient's got cat scratches or open sores or incisions. I don't know. I'll decide when I get in there and see the patient. Understand that gloves are not based on the skill. They're based on the patient you're doing the skill on. I won't know that until I see the patient. Good? All right. Going to get a barrier, put it on my table, get all of my supplies, not hold my linens against my uniform. Put the linens on the table. I'm going to get some water using a paper towel to turn the faucet on. It should feel warm, not hot, not cold, just warm. And I'm going to ask my patient to check it. Then I'll soak the hand in the basin. Once the hand is soaked, I'm going to pick it up and put it on a towel next to the basin. You want something soft for that hand to lay on. Remember, they don't have that fat protective layer. Put the hand on a towel. We're going to get some soap on our washcloth and wash the hand. Not in the basin, out of the basin. Wash the hand. Once the hand is washed, we'll put it back in the basin to rinse. Then we're going to take it out and put it back on that towel to dry. Now, if I were doing 2 hands, I can do them at the same time. Our care plan tells us to do 1 hand, and they don't care which one it is, pick one. But if I were going to do 2, you can do them at the same time. 2 hands fit in a basin just fine. Or you could do them 1 at a time.
Can you do it that way even if the difference is one? Or that's only if it says two?
Only if it says 2. Yep. Remember, we follow the care plan. So if the care plan says 1 hand, should I wash 2? No. I should only do 1. And for the test, it will only be 1. Good? Then I'm going to take an orange stick. An orange stick, some of you know it as a manicure stick. Looks like this. An orange stick has a beveled end and a pointed end. We use the beveled end like a scoop. And we insert the beveled end underneath the nail, swirl it around so that we get all of the debris that is underneath that nail. And then before we go to the next nail, we got to get rid of that junk. So we're going to get the junk under the nail, and then we wipe it off on the towel before we move to the next nail. Clean that nail, wipe it, clean that nail, wipe it, clean that nail, wipe it, clean the last nail, wipe it. Once we've cleaned the nails, we can file the rough edges. We always file in one direction toward the center. One direction toward the center. Don't go back and forth really fast along the nail. What that does is it pushes and it pulls the nail along the central axis, and it causes longitudinal stress on that nail bed, and you can actually split the nail right in the middle from tip to cuticle. I mean, it splits it all the way down. The nail will come off, kind of like ladybug wings. It's awful and horribly painful. And that happens when you go back and forth and it just pushes and pulls the nail like this, and it ends up splitting in the middle. So we only file in one direction toward the center. Now that tends to happen more with age because nails get brittle as we get older and that back and forth stress. Young people, you guys can tolerate it. That's why they do, back and forth really fast in the nail salons, but you really shouldn't.
So towards the center, does that mean towards the thumb?
Well, it means like I'm going to go this way and then this way. So like a point. Yep.
Okay.
And then I just kind of round off that point by going straight across.
Okay. So it doesn't matter like which way we go as long as we only go that way. Towards the center
Right.
of the nail.
Right. Right. The biggest thing is not back and forth along the nail rapidly. That's all they're looking for. And believe it or not, that's not even a graded checkpoint. Filing the nails is the checkpoint, not how you file. Yep, I want you to know that because we're going to be working primarily with older individuals. And I have seen nail care take a nail off. And that little old lady cried for days because it hurt.
Also, if they're diabetic and you scratch their hands with the filer,
Yes.
it could cause them to lose the entire finger because if diabetics don't heal the same, it
Right.
can also make it a bigger split if you get a little cut at the nail bed or anything like that.
That's why we're not allowed to use nail trimmers, is because of diabetics. Yep. It's really easy to clip the skin.
One small cut could never heal and eventually cause them to lose that
Yes.
portion of their nail.
We're going to talk about diabetes in detail on Wednesday, I believe. Is it Wednesday? Yeah, Wednesday. All right. We'll put some lotion on. Make sure you're supporting the wrist and arm at all times when you're moving the hand, right? We don't want to just manhandle them. Support that wrist and arm. We're going to warm up the lotion and put it on wiping off the excess lotion when we're done. Okay. Everything dirty would go in the dirty linen. You can, as you're using your washcloths, you can set them aside on the barrier, not on the table itself. It's got to be on the barrier. But you can set your dirty washcloths aside on the barrier. When you're all done, bundle everything up, take it to dirty linen. We'll rinse, dry, and store the basin using basin cleaning that we've just learned. And then we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Bed's in low position. Environment is clean. Here's your call light. Open the curtain. Wash my hands. Make any corrections. Tell the evaluator my skill is done. Good? That is hand and nail care. Please remember that hand and nail care, this care plan that we're looking at here for the test is only for this person. That's it. This care plan doesn't work on this guy or that lady or anybody else. This is just for this one person for the test. Every care plan you get for hand and nail care out there is probably going to say something different because it's based on the needs of that patient, not this one. Good? Good? All right. Jake. Throw the hand care video up, and then after the video, we're going to take our break. No, it should be desktop. Yeah. Should be 2025. Desktop.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the overbed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces, making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way, it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide this basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables. So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands.
After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Okay, we're going to go ahead and take our break, come back in 15 minutes. Phew. Ah. Okay.
Buddy, I had a dream.
Yeah.
I was caring for a patient, and I was insisting that they cover their nubby.
Knobby knees.
And this guy was like, "Aren't you calling me names?" And I'm like, "No, I just need to cover your knees."
That's funny.
I was like rewatching that same video, and my brother-in-law heard you say that, and he just started laughing.
Yeah, I have a way of saying things that's going to stick in your brain for like ever.
I was scared when I woke up. I'm like, "What am I dreaming?" It's too soon.
I had a weird dream last night too. It really doesn't even make sense in my mind, but somebody, I was at a football game, like on the sidelines of a football game, and this coach on the other side, the other team's coach, had these like fake hands. And he was like clapping at the players. No, they were like plastic big hands. Yeah, but big. like Hulk hands, but not green. Where does my brain come up with this stuff? Weird. Yeah. I always have weird dreams. Yeah, I have very vivid dreams. All right, so moving on. Change an occupied bed. This is probably one of my favorite skills. This is like a Houdini skill. Changing an occupied bed is not nearly as hard as you think it is. It takes longer to change a bed with somebody in it than it does to change a bed without somebody in it. So if you walk by a bed that's empty, you should automatically consider, do I need to change those sheets? Because you can change an empty bed in like a quarter of the time it takes to change the sheets with somebody in bed. So if somebody's out of bed in, like the shower room, or because even bedbound patients we take to the shower room a lot on stretchers. They're PVC stretchers with like mesh sling. And we can get patients out of bed and into the stretcher and take them to the shower room for an actual shower. Well, in that case, if the bed is empty, change the sheets so that we have a clean body in clean sheets, and they'll rest so much better. Or if the patient is out of bed in a procedure, or if they're out of, for whatever reason, if the bed is empty, change sheets. But there are some situations where we really can't get around it, where the patient is in bed, the sheets need to be changed either because they're soiled or it's been too long or whatever. We have to know how to do this. It's not a hard skill. It really isn't. All you got to do is change the bottom sheet a half of bed at a time. That's really, and I'm going to show you a procedure to help you with that, but that's really what we're doing. We're just changing that bottom sheet a half at a time. We're going to use some principles for this, obviously. Our page 141 in your book gives us our overview of this particular skill. So down the side, you can see all the principles involved. They're all spelled out for us here. Test-specific information is at the bottom. Somebody with your level of experience, which is none, should be able to do this skill in 14 minutes or less. So I just redid all these videos, just finished the editing. You guys are the first class that gets to see all the new videos. Every single video that I did, that I edited, we taped, physically performed 3 to 5 times. And then I take portions of each one and stitch it together to make the video, because there's different camera angles and different ways of presenting the information. Well, every single video that I did, I paid attention to this, the amount of time that you as a student have to be able to perform the skill within. every video demonstration that I have comes in under that time. And I don't cut corners. I mean, everything is done so that there's basically what I'm plus I've got the whole intro and the whole credits and all of that as part of the time too. So what I'm saying is, even though this may look complex, you have 14 minutes to do it, and the video only took 11. So lots of time there for you. But you are going to have to practice the skills at least once to become familiar with the steps in order to get it within that time frame. Let's talk about timing for just a second, though. If you go over time for the test, it's not an automatic failure. If you go over time for the test, you just don't get credit for any steps you didn't do. Remember that your closing makes up like a quarter of your steps. So if you start to run low on time, hurry and get the closing done for that last skill, because that's going to give you a lot of those checkpoints that you need. For the test, if you get close on time, they're going to give you a 5-minute warning. So you'll know kind of where you're at. Okay. My students generally don't time out. There's no reason to time out. All right. Step-by-step instructions located on page 142. Care plan is at the top. Supplies are at the bottom. Here's our care plan. It says change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. The resident can roll and move as directed. They just can't get out of bed. So we can ask them to turn on their side. They're not immobile. They're not comatose. Don't let your brain make this dramatic. They just can't, they just can't get out of bed. Okay, good. All right. Says a bedspread, blanket, draw sheet, or underpad are not required for this skill. So this is simply bottom sheet, top sheet, pillowcase. That's it. That's all we're doing here. And they give you 14 minutes to do it. It's crazy. Lots of time. Now, there is a principle here we have to talk about that we skipped on linen rolls. So for linen rolls, we learned linens can't touch your uniform. You have to have clean hands to get your linens. We don't want to snap or shake our linens, and anything we don't use, we discard. We've learned those. But there was something, or actually two principles on here that we skipped over. One of those we're going to cover now. Clean rolls toward me, dirty rolls away. And this is how we're going to change from dirty to clean. We're going to use this principle. So clean rolls toward me, dirty rolls away. And we're going to use this whether it's a sheet or a chucks or anything that's going underneath the patient. Clean rolls toward me, dirty rolls away. Now, the reason for that, let me get this to show you. Let's say that I have a sheet on a bed. Everybody see my sheet on my bed? This is a dirty sheet, and that is my patient, small patient. If I want to change this sheet, clean rolls toward me, dirty rolls. This is the dirty one, so it's going to roll away. So I'm going to roll this away from me. The underside of the sheet is what's facing up. Not the part the patient laid on, the underside of the sheet. Do you guys see that? Okay. So the underside of the sheet is what's facing up. Now I'm going to take the clean sheet, stretch it out, and I'm going to roll the clean one toward me. And again, when I roll it toward me, the underside is what's facing up. Now I'm going to take this clean one and tuck it up underneath that dirty one. Go around to the other side of the bed. Have the patient turn over. And we can get rid of that dirty one and smooth out the clean one. And all that touched on those sheets is the underside of the sheet. But you have to remember there's still a patient in the bed. This isn't a sterile procedure. Your patient is laying on the dirty sheet and laying on the clean sheet. So you're going to get some pathogen transfer, and that's okay. What we're trying to do is get it cleaner. Good? Makes sense? So a lot of people get hung up on that. Well, the pillowcase is touching the clean sheet. The dirty pillowcase is touching the clean sheet. So is the patient. It's not a sterile process here. Okay? Make sense? Got it? We're just trying to get the bottom sheet cleaner. Good? Now, what if, let me go back here real quick. What if that bottom sheet that we're taking off the bed, what if it's wet all the way through? What if they had a night sweat, or they had an accident, or their catheter leaked, or their wound drainage got everywhere? What if this sheet is wet? Well, if I put this dry sheet right underneath the wet sheet, that dry sheet's going to get wet. That's not really going to help us a whole lot. So what I would do when I roll this dirty sheet up toward the patient, I'm going to take a barrier and wrap it around this sheet, this roll, with the absorbent side facing in. So the waterproof side is facing me. I'm going to wrap it around that roll so that when I put this underneath, that liquid, that moisture isn't going to get onto my new sheet. Does that make sense? Good? All right, our care plan told us that a bedspread, an underpad, a draw sheet, nothing else was required. Bottom sheet, top sheet, pillowcase is all we're doing here. But what if I did want to put a draw sheet or a underpad on this bottom sheet? Well, before I roll it, okay, I have my clean sheet. I rolled my dirty sheet, tucked it under my patient. I have my clean sheet. I've kind of stretched it out, laid it over my patient. So I've got this clean sheet here. I would put whatever else needs to go under the patient right in the middle. When I roll it, I roll all of it. All of it. And that way, when I get to the other side and unroll it, it's all there. Good? So you use the same process. Doesn't matter how little or how much you're putting under the patient. It all goes in together. Any questions? All right, our other principle that we had to learn here is that we don't let anything touch the floor. Not clean, not dirty, nothing. And this is a problem for us for this particular skill because how many of you guys have changed your sheets on your bed at home? When you take those sheets off your bed at home, where do you throw them? Most people throw them on the floor as they're changing the sheets. And then once you're done changing the sheets, you gather them off the floor and take them to the laundry room or dirty linen or whatever. We're used to throwing our dirty sheets on the floor. We don't think twice about it. We just take them off the bed, throw them on the floor. In a clinical setting, can we do that? Nothing goes on the floor. So we've got to be aware of this for the test. You can't throw stuff on the floor. So what are we going to do with it instead? We'll get to there in just a second. So this is a visual example of clean rolls toward me, dirty rolls away. So the dirty sheet will roll toward the patient, tuck underneath. Clean sheet rolls toward us. We're going to tuck that clean underneath that dirty, protecting it with the chucks if we need to, if it's wet. Nothing goes on the floor. Not clean, not dirty. Nothing goes on the floor. In a clinical setting, we don't normally have hampers in the room. We don't keep hampers in our clinical area. They're usually in a hallway. We're not going to take the sheets off the bed and walk out to the hallway to put them in the hamper, though. So we've got to have a place to put them. That's where your table is going to come in. Barrier on the table, Remember, we don't put them directly on the table, put them on the barrier. So when you're doing this skill, you should have one part of your barrier that has your clean sheets. The other part of the barrier will be for your dirty. If they touch, not a huge deal because your patient is still in the bed, not sterile. Good? Makes sense? But there's a couple of different ways that we can handle this in a clinical setting. You can put a chucks on the table, put your clean and dirty on the chucks, that's fine. But in most clinical settings, we're going to actually use a special bag. Looks like this. It's light blue, will be stamped with soiled linen on it. Have you guys ever heard of like the Tide Pods? You know, the little pods you throw in the washing machine. You know, now they have these little sheets that you can get. They look like fabric softener sheets, but they're not. They're you throw them in the washer. You guys familiar with those? And they dissolve. You guys hear of those? All right. These bags are the very original version of that. These bags have been around for like 30, 40 years. They are soap. The bag itself dissolves and becomes laundry soap. So you're going to see these bags in a clinical setting on a roll like trash bags. You grab one, you open it up, you put it in your room, you put all your dirty stuff in the bag, and then you put the bag in soiled linen room. There's a soiled utility room you put it in. When you do that, that bag of linens goes directly into a washing machine somewhere. Sometimes in the facility, sometimes they outsource it, but that whole bag goes into a washing machine somewhere. That means that whatever's in that bag is going in the washer. Nobody is taking those linens out, shaking them out, and making sure that there's no hearing aids or dentures or cell phones or anything else in the bag. When we change sheets, it's our responsibility to make sure there is nothing foreign in those sheets. Okay? That facility is going to have to pay for everything we ruin. So nobody's going to shake them out. So remember, if you're using a soiled bag, whatever goes in the bag gets washed. You can also use a chucks on the floor. That's fine. Just no linens, directly on the floor. Has to have a barrier in between. And of course, there's a hamper in the hallway as well. Every facility has a room on the unit called a soiled utility room. This room is specifically for anything unclean. So dirty linens go in there. Used food trays will go in there. This is where all your dirty stuff goes. We don't like dirty stuff in clean environments. We don't like it. So we have to have a special room specifically for it. No clean items ever go in dirty utility. No dirty items ever go in clean utility. So clean utility is where you'll find a lot of your supplies. Dirty utility is for everything soiled. Now, one of the things that's in dirty utility room that I want to bring your attention to, there's going to be something in there that looks like a toilet, but it's usually square. You know how toilets have a round bowl? This usually has a square bowl to it and no seat. So like it looks like a toilet, but if you tried to sit on it, it would be very uncomfortable. This is actually called a hopper. It's not a toilet, but it functions like one. And it's used specifically for sheets and other articles that have solid waste on them. So feces, you would take the sheet, put it in the hopper, hit the flusher thing, and water's going to come out, and it allows you to kind of rinse the solid waste out of that and flushes it down, like a toilet, flushes it down. But that way, when you put the sheet in the bag, it doesn't have solid, because remember, everything in that bag goes into the washer. Okay, so those are called hoppers, and they're used mainly for solid waste. I'm plugged into a lot of CNA groups online. And one of the things that I'm seeing more and more lately, and it just makes me want to bang my head against a wall. There's a lot of CNAs out there that are throwing sheets away, throwing them away because they don't want to clean them. They don't, they're solid waste, and they will throw them. They put them in a trash bag and throw them away rather than getting the solid waste out and sending them to laundry. How expensive are sheets? If you guys had to buy a new set of sheets every day, would you be able to afford that in your budget? Your facility can't either. If you're wasting resources like that, they're not going to be able to give you a raise, guys. There will be no money. So the other one that I'm seeing a lot of is people are throwing bedpans away. Same reason, they don't want to clean them. I get it. I understand that it's yucky, but this doesn't make any financial or environmental sense. We've got to do a little better than that. Okay, good. Don't throw this stuff away. All right, so remember, use it or lose it. We don't leave it for later. All right, so now we know all of linen rules. Let's move on to scoot and roll. This is going to be, I'm going to get into this a little bit more in a later lesson tomorrow or Monday or Wednesday or Monday. I can't remember which. I'm going to go through this really quickly. Side rails are a restraint. Anything that is intended to restrict an adult's movement is a restraint, period, end of discussion. Side rails keep a patient in bed. Therefore, they are a restraint. CNAs cannot initiate side rail use. Only a doctor can do that. So in most settings, you won't even have side rails on the bed. They won't even be there for you to be able to use because they're considered a restraint. There was a situation about 3 years ago here in Florida. A nursing home got in a whole lot of trouble because the night shift was drugging every patient in the facility with Benadryl at dinner. Every patient with Benadryl, putting them all in bed, putting all the side rails up, and then completely neglecting the patients all shift. Well, all of them got fired. Most of them got reprimanded by the Board of Nursing. Yeah. But this was, this was from the nurses to the CNAs. This was a concerted effort because the shift didn't want to work. They literally were sitting around watching TV, collecting a paycheck.
And I heard that nighttime is way easier because
So yes and no. Every shift has pros and cons. That's the first thing you have to understand. Every shift has good and bad. You have to kind of think a little bit about your own personality too. How many of you guys are early birds? You like to get up before the sun. You function well in the morning, right? I got some early birds here. Okay. How many of you would sleep until 9 or 10 if you had the ability to every day? That's me. Yeah. Yeah. I'm probably on that train too. How many of you guys kind of come alive at around 4 or 5 in the afternoon? Anybody? That's when I do my best work. Between 4 and 10 is when I do my best work. Leave me alone. I'll go to bed about 2 a.m. and get up around 10 or 12, right? And I do my best work somewhere between 4 o'clock on. That is my circadian rhythm. Unfortunately, I'm forced to live in a world where the morning people rule. I don't like it, but I live here, so I have to adapt. Every one of us has our normal circadian rhythm. If I have to work an early morning shift, 7 A to 3 P, if I'm working day shift, I don't care what I'm doing. It's automatically going to be a struggle for me because that's not really where I function well. So when we talk about day shift is easier than night shift or night shift is easier than day shift, we have to take this into consideration because it's going to influence our perception of what shift is best for us. So you have to think about things like that. Make sense? Okay, then on top of that, you have to think about the patients. So now that we've got us taken care of, let's think about the patients. Well, day shift, you have 2 meals, breakfast and lunch. So you're doing a lot, right? You're getting them to breakfast, you're getting them to activities, you're getting them to lunch, you're helping them with their naps or whatever the case may be. Very busy shift. You also have a lot of doctors coming in. You've got a lot of family visiting, very, very busy shift. So you probably have fewer patients because you've got more to do with each one. Now, afternoon shift, 3 to 11, you've got kind of frantic in the beginning, because you're getting them ready for dinner, and then we have dinner, and then we have PM care, which is getting them ready for bed. Some people have to bathe, definitely some mouth care, you're getting them ready for bed. But then somewhere around 7, 8 o'clock, things kind of slow down until 11. Well, you're not going to be sitting around, during that time, because you're probably going to be restocking your supply room or cleaning the wheelchairs or, all the other things that day shift can't get to because they got so much going on. And then you've got overnight. Now, overnight seems okay because your patients are all in bed. That seems okay. Here's the problem. Number one is that most of your patients in a clinical setting are not what we would call normal. If they were normal, where would they be? Home, in their home. They're not there. So we have to understand that these are not going to respond the way we think they should respond. They are not going to go to bed and stay in bed all night long. Because if they did, where would they be? Home. So you have a lot of dementia patients who have sundowners, and 11 to 7 is going to make our life very interesting. On top of that, you have to fight the sleep monster because somewhere around 2 or 3 o'clock, even if you're a night owl, you tend to get the sleepies. And that can affect your ability to reason and rational thought. So you're fighting that. It's something that you have to kind of overcome. Now, so we've got patients that aren't staying in bed, and we have staff that aren't really with it, a certain portion of that thing. And then on top of all of that, a lot of your patients are going to have to be changed and repositioned every 2 hours, which can be very challenging because we're waking them up. And when you wake up patients with dementia, sometimes they don't go back to sleep. So day shift can be easier on some because a lot of your patients that have dementia are a little more with it in the mornings, easier to work with, but you got more to do. Afternoons can be easier to some because you only have 1 meal and you got some, kind of busy work toward the end. Night shift can be easier for some, especially if you're not, kind of a night owl. There's less to do, but your patients aren't always cooperative. In fact, rarely cooperative. So day shift, physical activity. Afternoon shift, a mix. Night shift, predominantly dementia activity. Does that make sense? So pick your poison. Oh, we're not going to go there. We don't even talk about that. All right. So side rails are considered a restraint. Anything that restricts a patient's motion is considered a restraint. CNAs cannot decide to use side rails. The doctor has to do that. There's a different type of side rail, though. Well, let me just go over this really quickly. When you're a baby, they put you in a crib. Once you reach about 1 year old, what do you start doing? Do you stay in that crib? You climb out. So how many of you guys still sleep in a crib? When you start climbing out, you are a safety concern now because falling from a low position is okay. Falling from a tall position is injury. So when you start climbing out of that crib, they take you out of the crib and they put you in a toddler bed. You don't sleep in a crib anymore. In fact, you haven't since you started crawling out of a crib. Well, when we put a patient in a bed with side rails, what we did is make them fall from a higher height, just like the crib. These are dangerous to patients. If the patient doesn't want to be in bed, the side rails aren't going to keep them in bed. All you've done is given them an obstacle, one that's probably going to hurt them. Make sense? You don't need side rails. Now, one of the biggest reasons for side rails is, well, I want to keep my patient safe. I don't want my patient to fall. And if they get out of bed on their own and they're weak, they're going to fall. I don't want them to fall. I want to keep them safe. The problem with that logic is if you put a patient in bed and put their side rails up for safety, are you doing anything to make them stronger? No. All you're doing is keeping you from having to do the paperwork. It'd be much better not to use the side rails and get them up out of bed into the bathroom occasionally. Walk them around the hallway occasionally with help. Now you're strengthening them and you're keeping them safe and making sure their needs are met. Side rails aren't doing that. Good? Side rails are convenience for the staff. They are. They don't do anything to help the patient. So we have to be really, really careful about using them. Now, there's a different kind of side rail, though, I want to talk about. This is the reason we can't use side rails. Patients in bed will try to get out regardless of whether there's an obstacle or not. So the tall side rails, they'll fall over. But these, they'll go through. This kills, on average, 15 people a year. Even with our current rules. Even knowing that we can't use side rails without a doctor's order, these side rails kill about 15 people a year because patients trying to get out of bed get trapped. And if you get trapped here, it will absolutely kill you. Yes. About 15 people a year. Used to be way worse. We were killing hundreds. Hundreds. When I first became a nurse, a bazillion years ago, we were trained that when you walked away from a bed, you raised all the side rails. When I was trained as a nurse, that was the norm. All side rails up on a bed when you walk away from the bed. So this has changed in my lifetime. And hundreds. We killed hundreds of people with side rails.
I'm just confused. How does the side rail like get around their neck?
Because this, do you see here, this little V? Yeah, this little V. So let me turn it. It's two pieces so that it kind of joins in like a V shape. Well, that's where you're naturally going to try to get out.
So if they fall or like they
Slide.
it gets stuck in between those two
Yep.
railings.
Yeah, I can see that.
It can like break their neck, choke them.
It's horrible. Horrible. So keep that in mind. Side rails are a restraint. You will have a test question on that, written test question. Side rails are a restraint. They require a doctor's order. We don't get to make that decision. This is what we call an old-fashioned side rail, long-term care side rail. They look like rails. They go all the way across the bed. These are actually a little bit safer from a choking perspective, way more dangerous from a fall perspective. And that would be the type of side rails you'd see here. Guys, on the test, there will be no side rails, none. No side rails. But this is a different type of side rail. This is called a half rail. See how it's got at the front, it's just a half rail. Those are called positioning rails. They don't impede the patient's ability to get out of bed. These are allowed. The ones at the top of the bed. Those are allowed because the patient can use it to position themselves in bed. It doesn't impede their ability to get out of bed. Okay? Yeah. Oh, Max, thanks for your videos that helped me pass my exams on Friday. Congratulations, Max. Good job. I like your profile picture too. It's cool. All right, so half rails are okay. Half rails are good. Full rails, no. but we don't need side rails to keep our patient in bed. Our side rails don't help with safety. Patient in the middle of the bed, that's the best way to keep your patient safe in bed. If I put you in this bed and I asked you to roll on your side so you're facing that TV, you would not roll. You would scoot. You would shift. If you rolled, you'd be near the edge of the bed and your mind would go, this is not safe. So what you do, and you do this without even thinking about it, you shift your bottom sideways. So you stay in the middle of the bed, just facing a different direction. You do this without any thought on your own. Your patients do too. Keep your patient in the middle of the bed. That's the safe zone, and they'll never fall out of bed. Good? Okay. And your patients will do this automatically. Patients will do this. If you ask them to roll, they'll do that and keep themselves in the middle of the bed. But what if we're rolling them? If we are rolling a patient, we want to scoot them toward us first so that after the roll, they're in the middle of the bed. We're doing the same thing, just in 2 steps where you would do it in 1. We call this scoot and roll. What it means is that we're keeping the patient in the middle of the bed after the roll. But to do it, we're going to have them scoot toward us and then roll them away. Stay behind the patient's behind. Never roll a patient towards you. Most of their weight's along their back and shoulders and butt area. Gravity will pull them back. If that's on the other side of the bed, you can't control it. You want to stay behind them after the turn. Okay. All right. So keep them in the middle of the bed. Always turn them facing away from you. So that's scoot and roll. Good? Good. So you're not going to have side rails in all settings. They require a doctor's order, but we don't need them. Have the patient scoot towards you, roll away, stay behind, they're behind. Keep them in the middle of the bed at all times, and they're safe. So now that we know all of those principles, we can learn this particular skill. This is an easy skill. Beds have a couple of different adjustments. We have the head of the bed that goes up and down. We have the foot of the bed that can go up and down. And we have the entire bed that can go up and down. Now, right now in our society, we actually have beds that you guys can buy where the head of the bed goes up and down and the foot of the bed goes up and down, right? So they aren't limited to just hospital beds anymore. You guys all have the ability to go out and buy these at a mattress place. I want to get one, right? Head of the bed goes up and down. Get yourself really comfy in bed. I'd probably never leave. Huh? Yeah, yeah. So we have that ability and just for regular people. What we don't have is the ability for the entire bed to go up and down. The entire bed is pretty much stuck right where it is. It's on a bed frame, right? The entire bed doesn't go up and down. So when you get out of bed for your entire life, that floor has always been right where you left it. Never moved. You get into bed, you swing your legs into bed, that floor was right there, predictable. You go to sleep, you wake up in the morning, swing your legs out, and even though you're groggy, that floor is right where you left it, has not moved. Not a day in your life has that floor moved. Now imagine if tomorrow morning you expect that floor to be there and it's not. You're going to fall because you put your weight down anticipating that the floor is going to be there. If it's not, you're going to fall. So even though we have the ability to get beds where the head of the bed goes up and down and the foot of the bed goes up and down, the entire bed has never moved, and it will never move for consumers, but it does for healthcare workers because we are working on patients on those beds. And for us to bend for an extended amount of time can hurt our back. So we have the ability to raise the beds up to a comfortable working level. Make sense? If you raise the bed up, you have to lower that bed to its lowest position before you leave the room, because otherwise you have moved the floor. And if that patient goes to get up, they expect that floor to be right where they left it. If it's not, they will fall. So when we're talking about bed position, this skill specifically, it applies to all of them, but this skill specifically, changing the sheets on a bed requires that you bend for a long time. That can hurt your back. You're probably going to want to raise the bed to a comfortable working height for this skill. You have to remember to lower it at the end of the skill. You don't have to raise the bed. You can do this skill without raising the bed if you want. You will see me demonstrate it, not raising the bed, because I'm short. I don't have to bend very far. But most of you guys are taller than me. So you might find it more comfortable to raise the bed. If you raise it, what do you have to do? Lower it. All right. So we don't have patients on a bare mattress ever. So that's why we roll the dirty toward the patient, roll the clean toward us, and make sure that the two are together when we're changing the sheets. Don't take that sheet completely off the mattress and leave the patient on a bare mattress. That just makes sense, right? So remove the old, replace the new, one half of the bed at a time, using clean rolls toward me, dirty rolls away. We'll secure all of the corners, and we want to try to minimize wrinkles under the patient. Wrinkles can contribute to bed sores. We'll talk about that next class. Minimize wrinkles. We're going to put the top sheet on. We're going to make hospital corners. The test doesn't care. They have no checkpoint on hospital corners. They just want the corners of the sheet under the mattress. They don't care how pretty it is. Don't care. My grandmother would, but they don't care. All right, we're loosen the sheet over the toes, and we're going to replace the pillowcase. You want to limit the amount of time they're without their pillow. And that's uncomfortable to lay there without a pillow. So we're going to leave the pillow on the bed while we change that bottom sheet, while we put the top sheet on. Then we'll take the pillow away, change the pillowcase, and put the pillow back in. We want the opening facing away from the door because of infection control. Limit the amount of time without a pillow. This is our care plan one more time. Remember, our care plan is only for this person, just that one. It tells us to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but cannot get out of bed. A bedspread, blanket, draw sheet, or underpad is not required for this skill. All right, Jacob, go ahead and play this video for me.
Occupied bed.
Yes, please.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed, wrapping it in a ball so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet from the top and the bottom of the bed, and we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed, pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies, and I'll be right back. These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Lights coming on?
All right, any questions? No? That was not too bad. Like I said, I think that's my favorite skill. All right. We're going to get through this next skill very, very quickly because we still have to get to blood pressure. So the next skill is going to be range of motion, elbow, and wrist. It's going to be on page 78. If you look at the principles, there's nothing new to learn here. We know to follow the care plan. We know how to do the opening. We know how to evaluate if we need gloves. We know how to do the closing. So all that's left is just what's specific to this skill. Somebody with your level of experience should be able to do this entire skill in 4 minutes or less. It is a super short skill. It'll be done on a live patient. That person will be in bed at the beginning of the skill. Step-by-step instructions are located on page 79. And our care plan states, provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion, extension. Provide 3 repetitions of each exercise, and the resident is not able to help with exercises. So let's talk about the skill-specific steps. In order to do any range of motions, and we're going to learn 3 range of motion skills for the exam, we have to know what body part, what exercises, and how many repetitions. Where would I go for that information? Care plan. So this care plan is telling us the right elbow and wrist. That's our body part. Now we need to know which exercises. It tells us flexion, extension. And then we have to know how many repetitions. The care plan says 3. So we have all the information we need to do this skill. So we're going to read the care plan. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? I'm going to do some exercises. Is that okay? Close curtain, wash hands, get supplies. No supplies necessary for this skill. But we do want to evaluate if we need gloves. If I'm going to be doing range of motion on the right elbow and wrist, and the patient has an incision in that area, would I need gloves? Yes. So we'll evaluate if we need gloves. Anytime we lift a body part, we lift from below with a flat palm. So we always lift from below. We don't grab. Remember, minimize injury. We're going to move slowly and smoothly all the way back to the start position. It's not a full range of motion unless you end where you started. Flexion extension is up, down. So this is flexion extension. Flexing is bending a body part. Extending is straightening the body part, up and down. Abduction, adduction is side to side. Not all joints can move in all directions. Side to side. So this would be abduction, side to side. Rotation motion is around. Remember, not all joints can move in all directions. But our care plan, even though we know all 3 exercises, because as a CNA, those are the 3 exercises we can do: flexion extension, which is up, down; abduction, adduction, which is side to side; rotation is around. Those are the 3 allowed exercises for CNAs. Our care plan is going to tell us which ones to do. This care plan just said flexion extension. So that's it. As we do this, we're going to ask about pain and discomfort, monitor for grimacing or any signs of pain, and we're going to do our closing. So our care plan here, let's look at it one more time. It says to provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion extension. Remember, flexion extension is up, down. So elbow, up, down looks like this. How many times? Wrist exercise, up, down looks like this. How many times? Put an opening in front and a closing in back. That's the entire skill. That's it. That's it. So let me show you this video. As the video is playing, Jake's going to be passing out blood pressure cuffs and cans. All right, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Great. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, and I'll be right back.
Okay.
Okay, Mr. Jones. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
The first exercise I'm going to do will be on your elbow. We're going to bend your arm up and back down to the bed like you're making a muscle.
Okay.
We'll do this 3 times each, okay?
Okay.
So the first thing I'll do is bring your arm straight down. We're going to go all the way up and then all the way back down. Feel any pain?
No.
All the way up and all the way back down. Still okay?
Yes.
And one more. Very good. Okay, now we're going to work on the wrist. We're going to bend it forward and backward like you're revving a motorcycle.
Okay.
We'll do this 3 times. So forward and all the way back. 1. Feel okay? 2. One more. Forward and all the way back. Is there any pain or discomfort?
No.
Thank you. Is there anything else I can get for you while I'm here?
No.
A magazine perhaps?
No, thank you.
Are you comfortable?
Yes, ma'am.
Call light's right there. If you should need anything at all, please let me know.
Yes,
I'm going to open the curtain and go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
All right, any questions on that skill? We're going to learn 2 more range of motions throughout the program, so you'll see those steps again, just not on the elbow and wrist. We're going to learn range of motion on the shoulder and range of motion on the hip, knee, and ankle later on. All right, so let's talk blood pressure. Blood pressure is not tested on the state exam. This is not a skill that you will be asked to demonstrate. That doesn't mean you aren't responsible for the knowledge. You will have test questions on the written exam about blood pressure. I want you to know how to take a manual blood pressure because even though you'll be using automated cuffs in most settings, if that automated cuff gives us an abnormal reading, we have to be able to double check it manually to make sure it's a patient problem and not a problem with a malfunctioning machine. So we have to know how to take a blood pressure. You probably won't do it very often as a CNA, but you have to know how. So we're going to cover that now. Page 56 has our notes on this. But we actually saw this when we learned pulse last week. The heart on the left side of your chest squeezes. When that heart squeezes, it pushes out a wave of blood. That one pushes the one in front of it. That one pushes the one in front of it. You guys remember this? It's like standing outside at a faucet. Turn the faucet on and off, on and off, on and off, on and off. The water's going to kind of pulse out. When the wave is moving through, higher pressure on the inside. In between waves, lower pressure. What we want to know is how much pressure each time. When a wave is moving through, how much pressure is inside the artery? When the wave is not moving through, how much pressure? That's all a blood pressure is. That's why we have 2 numbers, a high number and a low number. How much pressure is inside the artery when a wave is moving through is the high number. How much pressure is inside the artery in between waves is the lower number. That's what a blood pressure is. If you were to cut open an artery, this is what it would look like inside. Don't try that. Don't cut into an artery. But if we could, this is what it would look like inside. We have names for this. The top number is when a wave is moving through, right? Maximum pressure. We call that the systolic pressure when the heart is squeezing. Think systolic squeezing. That's our top number of our blood pressure. The area where the heart is at rest in between waves, that is our diastolic blood pressure or lower number. So systolic is squeezing, diastolic is at rest. We have numbers for this. So systolic or top number, higher pressure, normal values is between 100 and 119. That's where we want people to be. That doesn't mean that most people are. That's where we want them to be. In America, we have good intentions, but a horrible diet. So 100 to 119 is our normal level for our top number. 60 to 79 is our normal value for diastolic or bottom number. So if I told you that a patient's blood pressure is 128 over 84, is that normal? What would we do with that? Okay. What if I told you a patient had a blood pressure of 92 over 46? Is that normal? Okay. What do we want to do with that? Yeah. Yeah. Probably a good idea for all of the above. Recheck it, make sure they're breathing, and report it to the nurse. Absolutely. What if we have a blood pressure of 114 over 72? Normal. We like that one.
I haven't seen those numbers in eons. All right, so we're going to use a gauge to get these numbers. And we're going to inflate. And as CNAs, we only go up to here, 160 to 180. We don't go past 180. 180 is our stopping point, period. End of story. 180, top number for us. What's our top number? Do not inflate your cuff to over here. This hurts. Do you know what effect pain has on blood pressure? Do you know what pain makes blood pressure do? Makes it go up. So if we're inflating to up here and then we get a high blood pressure, the blood pressure may not be high. It may actually have been normal, but we inflicted pain, which caused it to go high for the reading. So as CNAs, we stop right here. This is it. If the blood pressure's higher than this, that's not a CNA problem. That's a nurse problem. So we would let the nurse know the top number's over 180, and then the nurse has to go take it. Okay, good. We got a whole system in place for that. All right. So we need two pieces of equipment to make this measurement. We're going to use a stethoscope and a blood pressure cuff. So we're going to start with our stethoscope. Go ahead and pull out your, let me grab this kit since you're not using it. All right. Let's talk stethoscopes.
Everyone's got a stethoscope and one of those Febreze style cans.
All right. This stethoscope has two ends. It has this end, which is called the head, and then it has earpieces. Both of these need to be adjusted. This head of the stethoscope is one side, usually has two sides. Not all of them have two sides, but usually has two sides. One side, if it's flat, it's called a diaphragm. If it's curved and cup-shaped, it's called a bell. Some of them have two diaphragms, a big and a small. Some have a diaphragm and a bell, and some are just single-sided. They all work fine. As CNAs, we don't use this side. We don't use the bell. That's for heart and lung. We use this side, the flat. CNAs use the flat side. Now, what we're listening for is a wave of blood hitting the top of an artery, buried under muscle, fat, and tissue. We want the biggest microphone we can get to hear that. A wave of blood inside an artery. This isn't a big sound. We need a big microphone. So we want the largest diaphragm. Now, the problem is that this stethoscope has no idea which side I want to listen to. So this whole thing turns. The whole head turns. We want to tell the stethoscope which side we want to listen to. So right down here, you'll see a bar. The bar has a flat side. The other side is curved. Find your flat side if it looks like mine, if it's a double tube. If it's a single tube, if it doesn't look like mine, if it looks more like this, you're going to see a dot. Okay, everybody see that? Your dot, or if you don't have a dot, your flat side is your on side. Make sure your large diaphragm is facing the same direction as that dot. If not, turn the whole thing. Okay, good. Everybody got their dot and their large diaphragm on the same side. Okay. Now we're going to move on to the ear tips. This is the most misunderstood part of a stethoscope, and everybody uses them wrong. I don't know why. Your ear canals as an adult point forward. They're not straight. Your ear canals are not straight. They point forward. So when you put these in, we want to make sure they also point forward so that we're funneling the sound directly down our ear canals. We don't want these ear tips straight. Our ear canals are not straight. These ear tips should be slightly curved. And you can turn them yourself. You just turn them. We want these ear tips facing slightly forward. And when you get them in place, they should look something like what you see on the screen, or like mine, they should point a little bit forward. If you need to adjust yours, you can hold down here at the chin strap and then just turn them so that they're facing slightly forward. Not a lot, but slightly. Now, when you put them in, they have to face forward like this. Okay, they face forward. They always face your patient. Put them in your ears and then ever so gently tap your diaphragm. You should hear it very clearly. You hear it? Take your ear tips out, flip the whole thing backwards, put them in the other way, and do that again. You probably can't hear as well. Take them out, put them back the right way, put them in, and try one more time. They should feel more comfortable, and you should hear more clearly. Good. Number one error that students make when they're trying to get a blood pressure, if you can't hear the blood pressure, look at your stethoscope. Chances are you have it in backwards. I don't know why, but we all want to put them in backwards. Okay. The other, if you can't hear a blood pressure, check your ear tips. If that's okay, look down here and make sure your diaphragm is on the right setting. Good? Good. So when we had the scrub shop, we used to have people that would come in and pay like $200 for the high-end stethoscopes. And then they'd bring them back after a couple of days and say, it doesn't work. And I would just hand it to them and say, turn around, turn your ear tips around. You fixed it. So remember that the way your ear tips point is going to determine what you can hear. Okay, good. All right, so now let's move on to our blood pressure cuffs. These are one size fits most, not one size fits all. All right, so here's your cuff. One edge of your cuff if you have a professional cuff, will have a white stripe. This is your measuring guide. This allows you to find out whether your cuff is going to fit your patient. If you place this white edge underneath an arm, Jake, can I borrow you? That's okay. So if I am concerned that this cuff is too big for him because he's got very small arms, I'm going to take this white stripe and put it about an inch above his elbow and wrap it around his arm. If it wraps more than halfway around his arm, it's too big, and I'm not going to get an accurate reading. If I think it's too small, if I put it under an arm and I can't see either corner, it's too small. It's got to be between 1/3 and 1/2 the circumference of the arm. Now, hanging off of the cuff, you have two tubes, one leading to a bulb, one leading to a gauge. The gauge has a clip on the back. That clip, if you press down and open the top of the clip, slide it up the tab that's on the front of the blood pressure cuff, it should stay there. It should stay there. That way it doesn't fall off and bang your patient's wrist when you're trying to put the cuff on. Now, hanging off the other tube is your hand grenade. You want to hold it in your hand with the bulb in the palm of your hand and that silver dial between your thumb and index finger. Don't inflate your cuffs. Just hold the bulb in the palm of your hand and make sure that your finger and thumb can reach that silver dial, because your hand is going to have to control the air going into and out of this cuff. When you're holding that little silver dial and it's facing you, when that little silver dial is in your hand and facing you, righty tighty, lefty loosey. So that little silver dial facing you, you want to turn it to the right just until it stops. Don't over tighten it. Just until it stops. Then we would compress our bulb. Don't do this right now. We're going to compress our bulb until our cuff inflates and that needle gets no higher than 180. And then we're going to hold that silver dial with our thumb and index finger, and we're going to turn it to the left, lefty-loosey, ever so slightly. I'm talking Thumbelina size movements, tiny, itty-bitty. If I go, whoosh, have you ever had your blood pressure taken? They inflate it, and it goes, woo, and then they give you numbers. Yeah, they guessed. When that needle goes up and you start to let the air out and that needle starts to come down, you are in complete control about how fast that needle is moving. It is all you. All you. If that needle goes way too fast, that was you. If the needle stops, that's you. And it's all controlled by that little teeny dial. You're going to have to learn how to finesse this. Okay? We're going to get to that in just a minute. Do not inflate your cuff unless it's wrapped around something. There's a balloon inside. If it doesn't have something to press against, this dial will go out of calibration. So that's why you have cans in front of you. In just a few moments, we're going to wrap our cuffs around our cans and practice inflating and deflating, but not yet. Not yet. Don't inflate your cuff unless it's wrapped around something. Otherwise, it'll be out of calibration. All right. So we got to learn how to read this dial before we start practicing. So if you look at this dial, you can see that it's got markings in 20s. So I've got 20, 40, 60, 80, 100, 120, and so on. The big lines in between are your 10s. So if this is 40, there's 50, 60, 70, 80, 90. So that red arrow right there is pointing to 90. Even though it's not marked, I know it's 90 because it's the big line in between 80 and 100. Now the little teeny tiny lines, those are 2s. If this is the line for 140, that makes this 142, 144, 146, 148, 150. Here's the problem. We inflate this needle as it's coming down. Remember, it's coming down backwards. Keep that in mind because we're going to hear something. We're going to hear a thump. Where that needle is, the number that it's pointing to is our number that we're looking for. So this is coming down. So here's our 140. If we heard our thump here, that's not 146. This is 130, 132, 134. Okay, so the needle's moving down, but we have to count up. That can get confusing. Good? Good. Remember, our normal range is so small that if we get that wrong, we gave our patient high blood pressure. All right, so the bulb and valve assembly is what's going to control this inflation and deflation with that little silver dial, okay? We're going to inflate until our cuff reaches 160 to 180. We're going to deflate using our silver dial. And as that deflates, we're going to listen for sounds. But let me show you what's happening inside the body when all this is happening, because I think it helps you kind of put the pieces together. We have this cuff on the upper arm. As we put air into that cuff, it squeezes inward. When it squeezes inward, it closes off that artery, closes it. Nothing's getting through. As we deflate the cuff, right? So we're up here at 160 to 180. We start to deflate that cuff using that little silver dial. As the needle comes down, what's happening inside the body is this cuff is loosening up. And when it loosens up the artery. So we've got some waves sitting up here that are waiting to get through. Right now, they can't get through because the waves are bigger than the opening. So they're sitting and waiting. But at some point, that artery is going to be open enough that those waves can start to come through. Now, we're down here listening with our microphone. When those waves start to come through, the artery is so small and so compressed that as that wave squeezes through, it actually makes a sound. And it's a sound we can hear. It's a thunk sound. When we hear that first thunk, right? So it's going to be quiet, 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 and then we're going to hear a thunk. When we hear that first thunk, wherever the needle is on our dial, when we hear that first thunk is the top number of our blood pressure. So we inflated, it was quiet, 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 thunk. This is where our needle was when we heard that thunk. Can anybody look at that and tell me what they're twos. Each one of those little ones are twos, not ones. Yeah, sorry. 108. 108. So that's our top number. Congratulations, you just got half of the blood pressure. We're not done yet. If one wave could make it through, others can make it through. So now we're going to start hearing thunks. The first one is the one we counted, right? 108, first one. That's the one that is our top number. Then we're going to hear more thunks. We don't care about those. Thunk, 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 thunk. We don't care. What we're listening for now is our last clear thump. So thump, 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 and then they're going to stop. First and last. So if our first one was our systolic, what is our last clear thunk going to be? Diastolic, or bottom number. Good? So we're going to hear more thunk. So thunk, 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 thunk. But they kind of taper out. Thunk, thunk. And then you're not going to hear any more. The problem is that none of these told us which one was the last one. It just went thunk, 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 thunk. Oh, there's no more. So we have to pay attention because we don't know where the last one is going to be. It's only the last one when nobody else shows up after it. Okay. So if this, let me go back here. If this is where the needle was when we heard our last thunk, can anybody tell me what that number is? Yeah, just one tick above 60. Yep. I know it's hard to see from way over there, and it's blurry, I know. All right, so when we hear no more thunk sounds, we know that was the last one that we heard. So that's going to be our diastolic reading, or lower blood pressure. So this blood pressure was 108 over 62. Is that normal? Yes. Good job. Okay. That's a blood pressure. It's that simple. It is technically complex. There's a lot going on here because your hand has to control that inflation, deflation. Your brain has to control your hand. but it also has to listen for the thunks and see where the needle is on the dial when you hear the thunk and that needle keeps moving. So there's a lot of parts to this. You're not going to get it today. You're going to need to practice this. Once you get the reading, remove your cuff, record your reading. Remember, where you hear your first thunk is your top number. Where you hear the last thunk is the bottom number. Now, some of you are going to have trouble at the top with the first one because it's quiet. And some of you, your brains go out picking daisies when it's too quiet. You'll inflate the cuff and you'll deflate and you'll hear thunk, 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 hungry, thunk. What's thunk for lunch? Thunk, maybe thunk, taco, thunk, bell, thunk. Oh no, where was the first one? Okay, so some of you will have trouble on the top. Some of you are going to have trouble on the bottom. So you're my dancers, you're my rhythm people. My rhythm people have a hard time getting the bottom number because the problem is that if I type out some sort of a rhythm like this, you start getting into the rhythm and you start anticipating the next one. How many of you guys filled in that next snap? If you filled in that next snap because you were anticipating it coming, you're going to have trouble with the bottom number. Some of you are going to be like me. I had trouble with both. I was like, oh, wait, it's quiet. It's not quiet. Where did it start? I don't know. This is going to take a little bit of practice. No, because you have to keep listening. So you're just going to have to, it's practice. It's nothing but practice here. Now, we do have blood pressure kits that you guys all have in front of you. You're going to be practicing it just now, practicing inflating and deflating, but you can't take the kits home with you to be able to practice on live people. So you can get your own as you go. I'm considering possibly doing like a checkout system for mine, but I'm going to need some sort of a deposit, right? Because unfortunately, people don't always come back. So my suggestion would be to go get one. You go buy one. Yeah, you can get them at Walmart, at CVS, pretty much anywhere. Yeah. Once you have the basics down, any cuff will do for you. All right. So now what I want you to do is wrap your cuff around your can. You want to wrap it around so that that dial is facing you and the tubes are hanging down. Is there another? Let me just have my drink. This will work. Okay.
Same size.
All right. So you're going to wrap your cuff around your can like this. Hold it in your non-dominant hand. This extra flap that's hanging off, put it around the back and hold the whole thing like this. So it's out of your way. Hold your bulb and valve assembly in your dominant hand. Jake, see if you can zoom in on me, please. All right, I'm going to demonstrate this. Okay. Oh, that's good. All right. You guys see it? All right, I'm going to close my valve.
Hold on, sorry.
Oh, no.
Increase the focus here. There we go.
All right. I'm going to close my valve. I'm going to pump up. And then I'm going to hold this and open it ever so slightly. Do you see this rate? This is what your cuff should look like. Now it's going to slow down and try to stop on me, so I got to open it a little more. As it starts to slow down, I'm going to open it a little more and open it a little more until I get all the way to 0. If your needle goes, woo, you opened it too fast. If, yep, if your needle stops, you got to open it some more. So Jake, just, I want the valve, the gauge and the valve. There you go. All right. So let me show you how I'm working the, no, come out. Out. I want the gauge too. Yeah, there you go. All right. So let me show you this gauge. So I turn the valve to the right to close it. I pump it up. And then I turn it ever so slightly to the left. You can't even see me turning it, and my needle is already moving. Little tiny bits, little tiny movements. It probably will start to come down a little bit on its own, and that's okay because you've got so much residual pressure in there, and that's okay.
Just give a 200. So like that. And then
Try closing this valve all the way. There you go, all the way. Now try pumping it. There you go. Yeah, if you have that valve open, it's not going to allow it to build pressure or air inside the bladder. And the way I can describe it.
So that's a good rate. You just got to get better at your initiation of the. So open it a little more. Open it a little more. Open it a little more. Open. Open. There you go. There you go. Nope, that's good. That's good.
That's the kind of thought process you want to have with that. So slow and steady wins the race when it comes to bringing the pressure down in the blood pressure. It's
Go ahead.
like little increments, like she said. So you just want to see a steady decline. The slower that needle moves, the easier it's going to be for you to get your readings as you're hearing those thumps as well.
So when you do this, so the biggest mistake people make is they over tighten. When you over tighten, then you got to really to get it to loosen. So when I am tightening this, I tighten it with one finger, with my thumb. That just until it stops, but it keeps me from over tightening. Perfect. See how much more control you have?
I got from 180 to 0 without stopping.
Nice. Yep, all the way to 0. Good control. Yeah, open. Yep. Yeah, it's not a crock pot. You can't set it and forget it. You got to keep opening. Just little tiny bits, though. I mean, teeny tiny. Teeny tiny.
It's like once you kind of find like your rate at when it's dropping.
Yeah, this isn't on the state exam, thankfully.
I know I'm gonna have to do this.
Yeah.
Good. Yes. Good. Very good.
Depends on what setting you work.
Yeah. So sometimes, okay, so we want to close it all the way. Go ahead and inflate. There you go. Now open it. Yep. Just a little bit, little bit, little bit. There you go. Good. Oh, good rate. Good job.
She's doing 3 laps, and every time she'd make a full lap, I had to stop them checking her vitals 3 times every single day.
Is that too fast?
Yeah, a little too fast. Yeah. Try to slow down just a little bit. That's the hardest thing is it's such small movements that you want to make. Go ahead.
Yeah, oftentimes in the facilities will even have you use those too.
That much no, slower.
Blood pressure cuff.
Slower. Slower. So we don't want to open quite so much. When you do this, let's close it. Go ahead and inflate. And then I'm going to show you how much to open. Okay. Yep. Right there. There you go. Good, good, good. Yes, much better. Yes. Yeah. You can't, yeah. As long as it doesn't stop, you can't go too slow. Because remember, you have to hear a sound. Your brain has to say, hey, I heard it. Then your brain says, hey, eyes, where's the needle? And then your eyes have to look and see where the needle is. And then your eyes say, hey, brain, this is where the needle is. All of that has to happen before that needle moves on. About 20, 25, 30, depending on where you go. Yeah. You go on to Amazon, I think you can get some of them for like 15 or 20. Yeah. All right.
Oh yeah, there's rings on the bottom of those. Here we go.
Any questions on what we've gone over today?
Yeah, the first one is the systolic and the second one is the
Right.
The first one you hear and the last one you hear.
Yes. So in your book on page 57 is an activity in the gray box for you to do sometime, in the next couple of days. This will help you understand whether you got these concepts, and using the images, whether you can figure out what this blood pressure is. So this is kind of a good way for you to be able to practice what we learned in class today.
Also, if we start at like 180, we shouldn't hear anything before until we get at least to 120, right?
Right,
And
right.
then we shouldn't hear anything after we drop from 60. So really, we have to just pay attention between 120 and 60.
However, we have people, right. We're going to pay attention the whole way because we never know when they're going to show up. But yes, normal, if it's normal, you're not going to hear anything till you get way down to 120, below 120.
Yeah, but like to prepare for it, so like if you start, I mean, obviously we start at 180, and then once we get to like 130, just kind of, I mean, you listen the whole time, but it's like, you can expect
Zero in, zero in.
Yeah.
Now, remember, you can't tell by looking at somebody what their blood pressure is. Now, if we get, so let me take you through this real quick. We go up to 180, we start to come down and we hear thumps right away. What does that tell us? The top number is, or higher.
They might be having a stroke.
We don't know. Well,
They might be
we're
very ill.
we're not saying that they're having a stroke. What we're saying is the top number is above 180. We don't need to find out what it is. 180 is high. Who does abnormal? The nurse. So what would we tell?
You just go report it like, hey, I noticed that they had a blood pressure around like 180.
Higher than one. We don't know where it is. Because you remember, you have to have quiet to hear the first. If there's no quiet, we don't know where the first is. Now, let me explain to you why this is important. You can't tell by looking at somebody what their blood pressure is. And even super high blood pressures don't always have symptoms. My blood pressure has routinely been over 200 for the systolic and over 160 for the diastolic. So if you just started listening at 120, you would hear nothing on me because the sounds stopped way before that. I have a metabolic condition that causes episodic hypertensive crises where my blood pressure goes like super, super, super high. You can't tell by looking at somebody what their blood pressure is. So that's why I said we have to listen the whole way. But you're right, in a perfect world with good blood pressure, you're not going to hear anything below 120. So any questions? Yeah. Feet flat on the floor, arms supported, relax. I always tell everybody, think happy thoughts before I take their blood pressure. Think happy thoughts. Be pleasant. Goes on the upper arm. Yeah, and you listen in the elbow area. Yep. All right. So thank you guys so much. I know I kept you over. I'm so sorry. I will see you guys on Wednesday. Have a great day. Those of you who joined us virtually, thank you so much for tuning in. We hope to see you tomorrow for the game show at 11 a.m. and we'll see you back in class on Wednesday. Until then, happy caregiving. Bye.